and now it's Mayfair जो रात को गए थे हम लोग।
क्या
तो युवा फॉक्सी का वेन्यू चेंज करके फाइनली वो मेफेयर में ही है जो हम लोग गए थे रात को।
हाँ, अच्छा उधर ही है।
उधर फाइनल किया है एग्जैक्टली।
ओह गॉड, कब है ये?
20, 21, 22 दिसंबर में।
दिसंबर
I'd
20।
like to invite all of you as well, so we'll send the invites once it's ready.
या
Yeah. Abhishek, can we start now? Yeah.
Yes, we are live.
Okay.
So, good evening, respected faculties and all the delegates. I welcome you all on the behalf of Public Awareness Committee Foxy with North Zone, episode 20 for Corconnect live webinar. Coordinators for the today's webinar are Dr. Monica Umbardant and Dr. Shatabdi De. Dr. Monica Umbardant is
Abhishek, don't read. That's okay. Thank you so much.
Yeah.
Yeah.
Ma'am, I request all of the dignitaries to join for the lamp lightning.
असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्योर्मामृतं गमय ॐ शान्ति शान्ति शान्ति।
Thank you, Abhishek.
Over to you for further proceeding.
Thank you, Abhishek. I welcome all the esteemed faculty members and our guest of honor for today, Dr. Abha Madam and Dr. Anuradha Madam, today for the 20th episode of the Public Awareness webinar series. Today, as we are nearing the National Safe Motherhood Day, we have chosen the theme as respectful maternity care and as postpartum hemorrhage, where our esteemed speakers, Dr. Poonam Goyal Madam, will be speaking, and Dr. Rakhi Singh Madam will be enlightening us on the respective maternity care. The brainchild for this webinar is none other than our chairperson, Dr. Priyanka Roy. I welcome you to please address the gathering.
Thank you, Monica. Good evening, everyone. First of all, greetings of Eid and this festive season with a lot of New Year's coming up for all the regions. So I welcome all of you on this day, and I will thank you for joining us in spite of being in this festive mood. So I'd like to first of all thank, and this is a duty that I have to do, though it takes a couple of minutes, but I think I should thank everyone who have and welcome everyone who have joined us today. So I'd like to thank the coordinators, Dr. Monica and Shatabdi, who are always there for all the PSC activities, along with all the other PSC members. Conveners, Dr. Anita Sabarwal ma'am and Dr. Vidhu Motkil ma'am. Dr. Vidhu ma'am, I don't know if she has joined, but wishing a happy birthday as well today, ma'am. Chief guest, of course, Dr. Jaideep Tangsa, who was always very helpful, a resourceful person and always supports us in all our activities. Dr. Madhuri Patel, ma'am, the Secretary General, again, can always fall back on her and all for all our activities. And also Dr. Ajay Mane, sir, who very gives a brotherly advice for all that I ask him for any reason it may be. I would like to welcome our guest of honors, Dr. Anuradha Khanna, ma'am, and Dr. Abha Singh, ma'am. Thank you, ma'am, for joining us. It's a pleasure to have you with us. Our chairpersons today, Dr. Amita Gupta, ma'am, Dr. Surjit Kaur, ma'am, Dr. Anita Sabarwal, ma'am, and Dr. Gitanjali Kaur, ma'am. Thank you for joining us. I would like to thank our speakers, Dr. Rakhi Singh, ma'am, and Dr. Poonam Goyal, ma'am, for agreeing to address us on the important topics of respectful maternity care and PPH, the bundle approach. We're going to have an exciting panel on case based on PH to be moderated by Manju ma'am, Dr. Sana ma'am, and our expert is going to be Dr. Sangeeta Rai ma'am. Thank you for agreeing to be with us. Our panelists are Dr. Savita Tyagi ma'am, Kiran Chandana ma'am, Dr. Meenakshi Shud ma'am, Dr. Nigat Firdos ma'am, Dr. Alka Yadav ma'am, Dr. Ginni Gupta ma'am, Dr. Ritu Mittal ma'am, and Dr. Preeti Vais ma'am. Thank you so much being with us, and it's a pleasure to have you all. I'm sure the next couple of hours will be a very exciting session as well.
Priyanka, could I request you to introduce our guest of honor, Abha Madam?
Thank you so much.
Abhishek, can we have the slides, please?
It's indeed a pleasure for me to introduce Dr. Abha Singh ma'am, our guest of honor today. Sabha Singh ma'am has been the chairperson of the Medical Education Committee. She is currently the vice president elect for the next here in Foxy. She has held many posts like president of AOGD, president of NARCHI, etc. in Delhi and in other society, other committees as well. She has been an invited faculty of many conferences, national and international. I welcome you, ma'am. Requesting you
Thank
for a
you.
few words of words for everyone.
Thank you, Dr. Jainpur. So you have rightly chosen this topic today. Respectful maternity care is really required in the present time, as we hear from the patients that they will not like to go to the government hospitals, or they will not like to go to a certain hospital. The doctors, the nurses, they are all very rude and things like that, or somebody behaves badly with them. So we want them to come back to the hospitals and advise other people also to come back. And another thing is that you have to really address them nicely, so that they are not afraid of undergoing a normal delivery. And you can allay the anxiety, you can allay the pain by giving them some sedatives, or we can start in certain institutions we are giving epidural analgesia also. So that in that way also you can allay the anxiety and reduce the cesarean section rate also. And another thing is, which you have taken up a subject of concern these days, is PPH. So what happens, PPH can occur in any patient, any time, antenatal patient, or patient who has gone into labor. But yes, the patient who has had previous cesarean section, they are more likely to develop placenta accreta or placenta previa, and they are more likely to have these problems. So let us see what the speakers have to say today, and how to save these patients, and if you want, and if you can save the uterus for another pregnancy also. So thank you, Priyanka.
Thank you, Abha ma'am, for joining us. Thank you for this wonderful words. Means a lot to all of us. Thank you so much, ma'am.
Thank you.
I would next like to introduce our guest of honor, ma'am, Dr. Anuradha Khanna, ma'am. It's always a pleasure meeting you, ma'am. And recently I had the opportunity of meeting you at the IAG conference. Can I have ma'am CV slide, please? Yeah. Ma'am has been the ex-department head at the BHU at Varanasi. She has been the ex-president of the Varanasi Obsgyne Society, president of various organizations, and she has been the organizing chairperson of many organizations. It's always a pleasure to have ma'am with us. And ma'am, I would request you to kindly say a few words for everyone present.
Thanks, Priyankar, for this kind invitation. It's a pleasure to see you all. And the topic you have chosen, that is safe motherhood, along with the how we can proceed to take care of a mother in a very good way. I think it is the head of the unit. If head of the unit is very nice, very pleasant, very caring, and to understand the woman from depth of her mental and physical and pregnancy health, then nothing can be more than that. If she is right or he is right, then of course her team will be nice, the nursing staff will be nice, and also the lower employees will also be nice. So you see, the nice environment is to be created by the head of the family, no one else. If you are nice, definitely, and we have to behave each other, to learn to each other, to our colleague, to be nice in a good words, not like humiliating that you are J1, JR1, JR2, JR3, and shouting on each other. First, we have to learn ourselves, and that message will be passed in the society. So, what I feel is that's very important. Regarding the how to manage the case, how to take care, that we will be learning in this very nice webinar. So I will not come in that. We know all what is PPH, where we are going to get, what to do. It will be a good revision with all the remarks of the esteemed moderator, panelists, and speakers going on. But the most important thing, being a human being, we have to learn ourselves to become a good one, so that the message is conveyed to the society, to the patient, to the surrounding. Thank you very much, all of you.
Thank you so much, ma'am, once again for joining us and your words of blessings. It means a lot to have like teacher of teachers like you and Dr. Abha Singh, ma'am, to join us and enlighten us all. Thank you so much once again, ma'am.
Thank you.
So I would welcome again all of you at this eve of happy motherhood, safe motherhood day. where we welcome all of you to this platform for this program, and also would like to extend an invite to all of you for the another program that we are having tomorrow as well. That is 9 committees of Foxy getting together and doing the program tomorrow evening. We'll welcome you for that program as well. And first of all, I'm sure that it's going to be a scientific and a learning feast for all of you present here today as well. Thank you so much. Over to you, Monica, to take us through the scientific session, please.
Thank you, Abha ma'am, and thank you, ma'am, Anuradha ma'am, for being there for the inauguration. Thank you, Dr. Priyankur. I now declare that the inauguration is over. We move on to the first academics part of this webinar, that is respectful maternity care, a talk by Dr. Rakhi Singh madam. I welcome our chairpersons, Dr. Amita Gupta madam and Dr. Surjit Kaur for the same. Can we have the slides, please? Madam is formerly the professor and head of the postgraduate department of the SMGS Hospital, Jammu. She is the has a Foxy Achiever Award, and she is the officer in charge of HRCC under ICMR. She has been the undergraduate and postgraduate examiners for various universities, and she has been the past president of the Jammu OBGYN Society. We welcome you, ma'am. Our next chairperson for today is Dr. Surjit Kaur Madam. She is the president of the Jalandhar OBGYN Society and the vice president of the ISAR Punjab chapter. We welcome you, ma'am. I request Amita madam to please introduce our speaker, Dr. Rakhi Singh madam. Amita ma'am, please unmute yourself.
I invite Dr. Rakhi, who is the chairperson of Endocrinology Committee of Foxy, a vice chairperson of UP State ISAR, and she is a peer reviewer for Journal of Obst and Gynae, India. And she has so many awards and achievements to her credit. And without wasting time, I invite Dr. Rakhi Dhawan Singh.
Thank you, ma'am. That's an old CV, ma'am. I'm at present, I've finished my endocrine committee chairperson, and I'm as an ICOG governing council member.
Feathers in your cap, ma'am.
Thank you, ma'am, for the kind invitation. Today, we are all here for the respectful maternal care, and which is very important part of us, bread and butter of all the gynecologists. And we need to learn to respect all the pregnant females. That is the most important thing. And every country, community, or worldwide, pregnancy and childbirth are momentous event in the family of the woman and the woman's life itself. इसीलिए हम बोलते हैं the second life of the woman, what happens. And pregnancy is a physiological condition where the expectant mother anticipates the utmost care and empathy for the patient herself. And respectful maternal care, there are few things which bring harm to the patient. They don't feel comfortable. It could be because of the mistreatment or the privacy, confidentiality, dignity, information about the informed consent, family and the community support at times for the female all through her pregnancy may not be there. The quality of the environmental resources may not be there, or the effective communication may not be there. However, every day in all countries around the world, pregnant women seek maternal care from the health system in their countries, receiving ill treatment, which can range to various levels, from the relatively subtle disrespect of their autonomy, or it could be dignity, to outright abuse in the terms of physical assault, verbal insults, discrimination, abandonment, or detention in the facilities, at times due to failure to pay. These are normally not happening, but they are also happening many places in a smaller cities or towns, which has to be curtailed down. The silent suffering of the woman seeking maternal care from humiliation and abuse are most inhuman things which can be done to any pregnant female. It is a violation of the basic human rights of the female. It has to be highlighted as contributing to the woman not seeking care at all for subsequent deliveries, or delay in seeking care, or discouraging from other delivery healthcare facilities. There can be a moment when the patient is deterred about hearing all the stories in the nearby village of their own, that once they had gone for the delivery and they were not respected well, they were not treated well, they were harmed over there, they were hurt over there by pinching, beating, or something of that sort, because she was not bearing down or something. That will deter them to go to the hospitals and deliver. That has to be decreased all through. And the care has to be given to these patients. How do we give care? Care is basically, C stands for effective communication. A for a positive attitude has to be there from the healthcare provider. R is for the respect for the patient, carers, and for respect for the staff also who's taking care. And E stands for the environment conducive to care and recovery of the patient. It is not only the delivery, the post-op period also, the post-delivery period also, care has to be taken. There are various categories of disrespect and abuse which can be there, because the patient once delivered, you can leave the patient off in the labor room and not take care of it. She is not able to take care immediately post-delivery because her energy levels at times go down with a prolonged labor. And physical abuse or non-dignified care, non-consented care, or non-confidential care, discrimination, abandonment with the withholding of care, or detention in the facility are few of the categories of disrespect and abuse which can be faced by these females. And the respectful maternal care, the basic components are privacy and confidentiality. Whenever the patient comes, we need to take her into our confidence, talk to her nicely, whether she is having any problems in the house also, that is required to know. And informed consent has to be taken from her of her own choices, what choices she wants, where she wants the delivery, what type of delivery she wants it. And dignity and respect is both ways. If you give respect, she would give the respect to you. No harm and freedom from coercion, companionship and its benefits, equality of care. It is seeking and receiving maternal care before, during, and after childbirth on all these components. Respectful maternal care not only contributes to ensuring positive outcomes for the mother and the newborn, but also supports cognitive development of the babies later on in life. And privacy and confidentiality is the most important thing which the patient dread about it. And that has to be respected. Whenever we are examining, just curtain it down, get a private room, get a private area for her for the examination. Don't think that she is from a low socioeconomic or from any other class and just examine her in front of 3 or 5 people. It is disrespecting for them. Usually, awareness about raising information, sharing, and motivation building. Respectful maternal care is done by the healthcare workers, the ASHA workers. They also talk about it. They are also going into the interiors and talking to the patient and motivating them to get down to the hospital, and hospital delivery is increased. Therefore, the woman's relationship with maternal care providers and maternity care system during pregnancy and childbirth is very vital. So these ASHA workers also need to be trained at length, that when they are going and talking, they need to be very empathetic and talk to all these patients. And lack of privacy or confidentiality is non-confidential care and can be forced. Patient can be forced to undress in front of the others, and they tell it's okay, even if the others are there. What you're having is the same what they are also having. Let me finish my examination. At times, these things are told, and this is very disrespectful for the patient. And this will deter them off from not coming to the hospital again. Lack of the space of privacy, lack of confidentiality, discretion, perception that the provider or unnecessary views of women's intimate parts have to be avoided in the comments. Non-confidential care is sometimes situations can occur that the patient can deliver herself or by the other patient without the healthcare workers. If their healthcare workers are not available in the labor room and she's about to bear for the delivery, that is not a good sign. Patients can be asked to clean the bed without paying attention to her and her baby by the healthcare workers. at times. And non-confidential care is defined in category of disrespect and abuse. To this corresponding right is privacy and confidentiality. So we need to have the respect for these patients, respect them during labor, ask them to have sips of fluid continuously, keep them self-hydrated, have the food if required, the light food or liquids, what they require during deliveries. Patients have a right to privacy and confidentiality during the delivery of services, which include privacy and confidentiality during the counseling part, physical examination part, the clinical procedures, whatever we are doing. The staff also needs to be sensitive enough in handling the patient's medical records. There may be the medical records in the patient's file, if the patient doesn't want it to be revealed to all the others, the mother-in-law, or any other people who have accompanied. So be sensitive towards that. Or other personal informations if the patient wants to hide. That has to be sensitively handled. And providing privacy to the patient, pregnant woman during the intrapartum period by way of separate labor room or at least a private cubicle is necessary. However, it may not be possible in low resource settings. Then also just put a curtain over there. That itself will be doing great wonders for them. Therefore, we must do whatever possible to protect the privacy and confidentiality for our patients and keep mother and baby together all the time. Restricting ambulation, different positions during labor, and choice of birth or the positioning at times is important. Lack of companion or the family member during the labor and not allowing them to enter the labor room in the pre-labor phase or when she's not in the active labor. Overuse of anesthesia, analgesia, administration of oxytocin at any time before delivery in such a way that the effect cannot be controlled, restricting food and fluids, separation of the mother and the baby, early cord clamping, routine episiotomies. These are the common practices which are dealt at some places, which have to be curtailed down and decreased. Avoid all the unnecessary episiotomies if required and do the episiotomy how much ever is required. Give local anesthesia and then do it. Don't do the episiotomy without giving any local because that would increase the pain and further deter her further. The choice of the birthing position has to be respected. The patient has to be comfortable enough and ask for the analgesia if she requires it. The epidural analgesia can be offered and campaign during the pregnancy last trimester. Tell the patient that she can have a normal delivery. Advocate her all the exercises, the Kegel's exercise, the butterfly exercise, the butterfly exercise which she can do, the other exercises which she can do, and get her off the bed, help her out, justify interventions, listening to her all through, and give a positive attitude, promote skin-to-skin contact at times. There is also a need of a support person in the labor room before the patient enters into the active second stage of labor. The companion should be either the husband or the one preferred by the patient herself, because with whom she is very comfortable to communicate and talk all through her labor pains. The presence of birth companion improves the birth outcome and the overall birth experience. Continuous empathetic and physical support is associated with shorter labor and less medication and fewer operative deliveries because she is very comfortable all through her pregnancy, through her labor time. We need to keep the mother and the baby together, promote warming with a skin-to-skin contact after birth, promote early and exclusive breastfeeding, ensure that the mother is counseled about the dangers and the signs of top feed. The cord clamping ideally should be done after the pulsation stop, and a delayed cord clamping is important. And there are various benefits of having a delayed cord clamping. To summarize, equality Equity in access, empowering individuals have to be done. There should be no discrimination. No financial hardships should be conveyed to the patient so much that the patient is deterred to go to the hospital. Promote preventive, curative, and rehabilitative care. Timely focus on the treatments, on the emergencies, what has to be taken. And respect for the mother is when I get to be talked to politely by the service provider. The patient also says, respect means taking into consideration what my preference is. And when it comes to services throughout the whole process, respect means not only being harassed while at the clinic with the unnecessary interrogations which have to be avoided. Be clever enough in dealing with the patients. The clinical care, admission and triage has to be nicely completed. Labor ward management has to be adequate. The labor nurse has to be active enough not to leave the patient alone and take care of it. Eliminate all the barriers. Talk to the patient politely so that give respect and take respect comes. Verify all the documents, verify the patient batches, the labels are correct. And respectful care is important. Respect for ourselves guides our moral respects for guides our manners. We don't need to share the same opinion as others, but we need to be respectful. That is important. So when we are respecting our patients, when we are giving respect and privacy to them, we also expect and get the same thing from them. Thank you.
नहीं हाय तो नहीं है क्या?
Hello. Hello.
एक मिनट.
Am I audible?
Yes,
Yes,
yes.
Can I request Surjit madam to please give the concluding remarks for the talk, ma'am?
Thank you, Dr. Monica and the team for inviting me as a chairperson for this webinar and making a part for it. So there should not be a proper screening around the patient so that she should be examined in a privacy and delivered in privacy so that she is not ashamed and not fearful for the environment. And after that delivery, baby should be in close contact and early breastfeeding should be encouraged. So all the things very clear from Dr. Monica's talk, because respect to the patient is very, very important. A patient should feel very much secured in that environment while giving the delivery. Thank you, Dr. Monica.
Amita ma'am?
I just have to make one comment.
Yes, ma'am.
That even Government of India has started the Lakshya program for the same. That they were aware of the fact that in the government hospitals, due respect is not given to the laboring woman. So they have started certifying the hospitals with Lakshya scheme. So a lot of emphasis on respectful maternal care.
Thank you, ma'am. Thank you, Sujit ma'am and Amita madam for chairing the session, and thank you, Rakhi ma'am, for accepting our invitation at the last minute. Thank you so much, ma'am. Can we move forward? Yes, ma'am. Can we move forward to the next session? That is the PPH bundle approach by Dr. Poonam Goyal madam. Our chairpersons for today's session is Dr. Gitanjali Kaur madam and Dr. Anita Sabarwal ma'am. Can we have the slides, Abhishek? Yeah. Dr. Gitanjali Kaur madam is a director and senior consultant at Pal Hospital, Ludhiana. She has more than 26 years of clinical experience, and she's been the organizing secretary of the North Zone Yuva Fogsi and the president of the Ludhiana OBGY Society. We welcome you, ma'am.
Okay.
Dr. Anita Sabarwal madam needs no introduction in Public Awareness Committee. She is the North Zone coordinator for our committee. She has been the president of A4GD, that is the Forum of OBGY of South Delhi. And she has been the chairperson of the ISCCP Public Awareness Committee from the year 19 to 21. We welcome you, ma'am. And I request Anita madam to please introduce Dr. Poonam Goyal.
Thank you, Dr. Monica, and good evening, everyone. I'm really thankful to Dr. Priyankur also for giving me the opportunity to be part of this wonderful awareness program, which has been happening for the last, I think now so many months, I should say that.
Ma'am,
More than a
20th
year.
episode today.
Yeah, really, really great. So I'm really privileged, and I feel so blessed that I'm going to introduce one of the wonderful gems and jewels in the field of obs and gynae, our own Dr. Poonam Goyal, who is now also the chairperson of the Safe Motherhood Committee. And so very rightly, she's got this topic, which she will tell us, and you'll all know how wonderful she is, a great orator and a woman of substance. Because I'm from Delhi also, so I know how hardworking she is. Very talented,
Thank you,
beautiful,
Dr.
and
Anita.
a
Thank
very
you.
wonderful human being and a great friend
Thank
also.
you.
So
Thank
let's hear from Dr. Poonam Goyal. And I hope your husband is doing very well, because he met with
He
some
is
injuries.
okay
So
now.
good. Okay, Dr. Poonam, let's hear from you. Let's
Yes.
hear eagerly.
So
Waiting.
let me share my screen. अगर
Yeah.
हो जाए तो yes. Just 1 minute.
आजा तू जस्तो की ताला
Just 1 minute. बस स्लाइड वाला वो दिख नहीं रहा मुझे.
Ma'am, on the top side, there is a
हाँ
slide.
मिल गया हाँ हो गया. उसके ऊपर एक्चुअली कोई विंडो आ रही है तो इसलिए आई एम नॉट एबल टू सी द आइकन. सो ओके. Thank you so much. Thank you, Dr. Priyankul, for inviting me here today. Or Dr. Rakhi, your talk was superb. And thank you, Dr. Anita, Dr. Monica, for your invitation from this Public Awareness Committee and such a nice introduction. So our next topic for today is to talk on PPH bundle. PPH is the leading cause of maternal mortality worldwide. Each year, about 14 million women experience this horror and 70,000 maternal fatalities occur. And even when women survive, they may have lifelong reproductive disabilities.
Ma'am, it's not full screen yet. Can you please try to make it full screen if possible?
अरे वो हो ही नहीं रहा. अच्छा 1 minute. अब हुआ?
No,
Now
ma'am. Yes,
now
ma'am.
it's
Now
good.
it is.
Please go on.
Okay.
Yes.
Okay. So now what is PPH exactly? As we all know that if blood loss is more than 500 ml in normal vaginal delivery, and if it is more than 1000 ml in cesarean section, more than 1500 in cesarean hysterectomy, and if it happens within 24 hours after birth, or there are changes of 10% in hematocrit value falling to 10% of what was the original following the childbirth, or any amount of blood loss that makes the patient hemodynamically unstable. Now coming on to secondary PPH, it is the purpural hemorrhage which happens 24 hours to 12 weeks following the delivery. So PPH is considered moderate if the estimated blood loss is between 1000 to 2000 ml. It is massive PPH if blood loss is more than 2000 ml. These 4 T's, which are the main cause of PPH, and we all right and left are aware of these 4 T's, that is tone, thrombin, trauma, and tissue. If any of these 4 happens to be bad or disturbing, then there will be PPH. So what are the risk factors for PPH? It can be age-related, ethnicity, then grand multipara, over-distended uterus, abnormal placentation, previous cesarean section. Because of previous cesarean section, most of the patients may have this placenta, accreta, these kind of things. And as we all know that cesarean section rate is on the increase these days. So this is also another cause. Then preeclampsia, previous history of postpartum hemorrhage, chorioamnitis, maternal anemia, and coagulation disorders. Then prolonged labor,
And first stage, if more than 10 hours, second more than 2 hours, and third stage more than 30 minutes. Then augmented labor cases, then instrumental delivery if we are doing, then lacerations happening to cervical, vaginal, and perineal area, fetal macrosomia, then midline episiotomy by mistake if it is given or there is a tear, then epidural analgesia, then retained products of conception and uterine rupture. But just keep in mind that it is not always that you will find a risk factor. The PPH can happen to a patient who you always think that she is not at all risk of having PPH. So now relaxation is not always good. Most cases of PPH happen due to this atonic PPH, that is 75 to 90% cases. Most of the physiological processes in the third stage of labor remain unclear. However, primary PPH due to uterine atony occurs when the relaxed myometrium fails to constrict the blood vessels and it causes hemorrhage. As up to 1/5 of the maternal cardiac output, that is 1000 ml per minute, enters the uteroplacental circulation at term, and PPH therefore can lead to severe loss of blood, and that too in a very short span of time. That is the most dangerous thing. So PPH directly affects the maternal mortality rate in a community or in a country. And PPH is the sword of Damocles which is hanging over the obstetrician's head always. So what is the scenario in our country? You know, when we were students, like in 70s, then we used to read that maternal mortality rate it was around 1000 or 1000 something. But in 2014 to 16, it was between around 130, and it has come down to 97 in 2020. But due to COVID, from 97, it is still at 97 in 2023 statistics. Because of COVID, we had lots and lots of maternal deaths. And that is why this downfall has not been achieved in the past 3 years. Madhya Pradesh is the most affected state, you know, and Kerala is the best, having 19, and the capital city, that is ours, is having 77 maternal mortality rate. And that was the status of 2023. Now, here I go up on to 2013. Here you will see that in 2019, the maternal deaths happening worldwide were 5,23,000. In 2013, it was achieved to be 2,89,000. And nearly 800 women died at that time, 10, 11 years ago, every day. And this 800 has now come down to 70 or 80 something per day. But what the WHO and other people feel, that the effort which has gone in past 10 years, it has not brought the desired results in the decreasing the maternal mortality, especially in the developing countries. So earlier, you know, the maternal mortality was more because of this PPH, severe bleeding cases, that is 27%. But now this pre-existing medical conditions is almost competing with the PPH. Now the obesity, the diabetes, the HIV, these existing conditions are almost as culprit in maternal death as the PPH. So why the global concern came, and why it is still bad, it was tried to realize, people try to realize that why the desired results are not being obtained. So what they found was there was lack of adherence to the guidelines. There was absent training modules. Whatever your small institution will teach you, but that was enough for you to take. Then lack of access of supplies of various drugs, no concept of teamwork or tools. There was delay in care and transport of the patients who were sick, and there was lack of aggressiveness in managing such situation. That was the main thing. There was lack of aggressiveness in managing such situations. So WHO has now prepared a roadmap That is, by 2030, we should have this PPH 70-30. That is 70% reduction in PPH deaths by, just a minute. Sorry, forgot to. So 70% reduction in PPH deaths and disability by 2030, that bringing down that 70-80 figure to 30 by 2030. That is what is the aim of WHO now. So now WHO has been trying and revising the guidelines and all. In 2017, they recommended the use of tranexamic acid for the treatment of PPH, and then they recommended the use of uterotonics. Then your new uterotonic now have come, that is carbitocin we are using. Then 2019, they gave the essential medicine list, which should be present at every center who are taking the deliveries. So this is the emergency care bundle approach which came, and FIGO was the leading factor in bringing out this by the studies which were done at Massachusetts, at this Harvard University, and this was another NGO type people who were doing this. And then our institute, that is Vardha Sevagram, there also people are working on this like light and ref. They are training the people. Dr. Poonam Verma is there, and she is doing a real hard work. I feel I have seen her working. And then evolution of PPH emergency care using a bundle approach. Now, what is that? That is, its aim is to save mothers. It has a very less learning curve. Only hardly 2 to 3 days training will be enough for you to learn how to manage a case as a team member. Then it is suitable for all levels, maybe from PHC to tertiary care facility. Objective is to improve the PPH care at every obstetric unit. Novel way to conceptualizing the PPH emergency response. Integrates clinical interventions of rapid effective PPH emergency care. Non-surgical steps are relatively very simple to perform, so everybody should learn them. And evidence-based cost-effective interventions are there. So now, what is a bundle thing? Now the concept of so many bundles have come up. So what is a bundle? Bundles is small set of evidence-based interventions for a specific patient populations and care settings. It is a structured way of improving the process of care and patient outcome. When implemented together, they lead to a better patient outcome. Now, what are the examples? Now we have antibiotic care bundle, we have septic bundle, we have urinary catheter care bundle, central vascular bundle. So that is how we go. That is, we perform the same thing, but we perform it in a more effective way without lack of time, in a more aggressive approach is there. So now what is the goal? Standardized and expedite care protocol is there. Simple, organized patient care it is. Reinforce the team performance, and we reduce the variability in the patient care. Increased adherence to the recommendations, and it will definitely improve the outcome. So now PPH emergency training program. So this is what was recommended by WHO and FIGO and even our society, that PPH emergency response should be there with the respectful maternity care. Now, non-clinical thing is that teamwork and communication should be better, network integration should be better, facility readiness should be there, leadership should be there, so that whenever this happens, the senior person should take the control and start doing the things according to, everybody starts doing the thing according to what that person says. Then training program for this is, that is for over 3 days. First day is critical, non-surgical, clinical component of emergency response. Second and third day is non-clinical. Then teamwork and communication. These are essential elements of quality patient care. It emphasizes the 3 key processes, that is establishing an effective institutional emergency response through creating an obstetric rapid response team. So like in your hospital, you will see the announcements that this code blue is happening in that room and something like that. So there should be like rapid response team of obstetrics also, and that team should also be called on a public address system to come to OT immediately, using specific communication techniques, then conducting drills and simulations at the same time. Then facility readiness, the achieving and maintaining a state of preparedness in the facility, network integration that we just talked, then data monitoring and quality improvement, and leadership as we just talked. So now what is bundle? Bundle is first care bundle, your first response to PPH. That is first there will be trigger. That is, you will call that or define that patient is having PPH. Now, then the set of actions will start. Then you will do set 4 actions in that patient. Then there will be some supportive measures in that patient. Then you will do all those supportive measures. First and foremost important is to do AMTSL. AMTSL is active management of third stage of labor that we have to do, and it is a must in all the patients. So that is 6 important steps. That is, first we check the uterus for presence of a second baby. Though I think this has lost importance now, but that is a protocol which has been taught to us for ages. In less than 1 minute, administer a uterotonic drug which makes the uterus contract powerfully, be it oxytocin, be it carbitocin. Apply controlled cold contraction. After delivery of placenta, immediately start massaging the uterus. Examine the placenta to make it sure that it is complete and none of it has been retained in the uterus. Examine the woman's vagina, perineum, external genitalia for any kind of lacerations and active bleeding if present. So now everyone has done AMTSL, and some patients are okay, they are shifted in post-op care, and some are still bleeding. Then what we do? Then here comes the PPH emergency response. That is your first response bundle. These are the 4 steps we do. That is uterine massage, we give IV fluids, we repeat or higher dose of uterotonics are given, and then tranexamic acid is given. These 4 things are done by 4 different people. And those people are assigned already in your team that this person shall start this person shall do this person shall do this, so that there is no loss of time. And the drugs and everything is lying at their at your PPH tray, I would say, or some almirah or some place, so that they don't fumble around to try and find the drugs. So first is uterine massage. See the technique of the uterine massage here. The uterine massage involves placing a hand on the woman's lower abdomen and stimulating the uterus by repetitive massaging and squeezing movement. So this is what we do. Then we give the IV fluids. So most important thing is, whenever there is a labor patient in your labor ward, always admit the patient and then you give her this 18 number, that is the green cannula. You don't give this blue or pink, because these are low bore cannulas, and we need at least this 18. Because in emergency, you can just push the fluid more in amount. And whenever there is a problem and you need to put another cannula, always use this orange or a gray one. So these 3 should be handy in your PPH tray. So wide bore IV cannula is important. Then crystalloids should be there. Normal saline should be there. Linger lactate, hemaxil, that should be there. So then in your first response bundle, next comes the uterotonics. So in uterotonics, 20 to 40 units in 1 liter of normal saline to be given, 500 ml over 10 minutes. It is followed by 200 ml per hour. Then total dose should not exceed 100 units per 24 hours. Maybe sometimes the protocols are different at different institutions. So maybe some people give a little less earlier and more afterwards. So whatever it is, you can give 100 units in 24 hours. Then tranexamic acid, that is 1 gram in 10 ml within 3 hours of PPH. As early you will give, as good is the effect. Then repeat the drug in 30 minutes. But now we are having some recent studies have come up that this drug also has some problem. Some few, studies have come. They are saying that there is a higher risk of venous thrombosis overall, but still this drug is in the protocol because those studies are still conflicting, and you can use this drug. As of now, the status is this. So now then after doing your main 4 steps, then you go on to supportive measures. Now, what are these supportive measures? They are also as important as those first steps. Supportive measure first and foremost is to identify the laceration and then to stitch that. Suppose there is a cervical laceration. Unless we stitch it, we don't get control of PPH. So we need to do that. Then we should empty the bladder there and then, because Foley's catheterization is better to do because we can monitor her output also. Bladder is empty. Bladder empty will not disturb in the uterine contractions, and your assessment will not be affected by the distended bladder. Because you are pushing so much of fluids, there may be too much of sometimes pressure in the bladder, or sometimes too less when the patient is going into AKI. So we need to monitor the output also. So now then you have to check whether the uterus is empty or not. This is also very important. You can do it by ultrasound or by exploration, whatever the position of the patient or whatever is at that time available to you, that you need to check. Because even if you have checked that the placenta was complete and everything was okay, but still sometimes in 101 you will find in some patient there may be some subcingulate lobe or some other thing, or maybe some amniotic membranes have been left. So you need to check and empty the uterus. So these are the supportive measures of your first step. Now you have done everything. Your first step is complete. You are watching the patient, but the PPH is refractory. Now what to do? So these are the refractory PPH measurements. What are these? The first one is the compression, and then tamponade, and then this anti-shock garment. Then these are the final measures, I would say, rather than the supportive measures. That is, we need to complete the blood which has been lost. We need to refer the patient. If our center is not well equipped, if our center is well equipped, then we straight away move to surgery. Otherwise, at the referral central, patient will end up in surgery. So this is compression. Compression is one is uterine compression that is done bimanually, and for ages we have been doing it and we know what it is. So now this is bimanual aortic compression. Most of the times we are not doing this. So please learn this. And I would suggest whenever you are examining a patient of thin build, please, maybe non-pregnant or any, you just try to keep your fist on the abdomen, just left of the umbilicus, and you will see pulsations. You will feel pulsations there, and that is what you need to compress at this time. So try once or twice and see, and you will definitely feel the pulsations of the aorta on the abdomen like this. So now uterine balloon tamponade. Uterine balloon tamponade is recommended for the treatment of postpartum hemorrhage due to uterine atony after birth in women who do not respond to standard first line of treatment. Now you go for the balloon. Immediate recourse to surgical intervention and access to blood products is not possible, even at a tertiary care center also, because you will just send the requisition of blood, the blood will come and everything. For that time also, you can put just this tamponade. A primary postpartum hemorrhage first line treatment protocol is this, and this should be available in your unit. The other causes of postpartum hemorrhage like retained placenta or lacerations, etc., that should have been excluded before putting this tamponade, because then otherwise it will create another ruckus for you. Then uterine balloon tamponade, you can use Bakri balloon, but if the cost is an issue or your center or your resources are less, then we can make this a Foley's catheter, and then you just put a condom over the catheter, and then you can just push the fluid, put a rubber band here and tie here. So this also helps, and it is sturdy enough. I have personally used it, and this is good enough, not a problem. This is another kind of balloon which has come up here. This goes into the uterus and this goes into the cervix. So if there are cervical lacerations which you are unable to stitch, or which are not like that you want to stitch them or cut through or something like that, then you can use this kind of balloon also. Now coming on to the non-pneumatic anti-shock garment. This concept first time came from anti-gravity uniforms which were designed by NASA. It is made of neoprene-like material which has very strong Velcro closures. So temporary life-saving measure, and it is designed to be wrapped around lower limbs and abdomen of the patient who is experiencing bleeding. It applies circumferential pressure to the lower limbs and abdomen, thus prevents pooling of blood in the lower extremities. So that saves a lot of blood, and blood is then directed to the important organs. So it reduces blood flow to uterus and bleeding stops as if you have ligated the internal iliac. It can keep women alive for 48 hours. But it is suggested that 24 hours should be the cutoff before you do your another things or shift the patient. 48 hours is a little too much, but people have used it for 48 hours also and had good results. Without it, she may bleed out everything in 30 minutes. In this silver hour or golden hour, whatever you say, we can plan surgery and can shift her to a tertiary care center. We can arrange blood, we can call for help. This garment is endorsed by WHO, UNICEF, FIGO, Fogsi, UNFPA, and everybody, just endorses this. But what I feel is that in ours, hardly 40 to 60% of PHCs who are conducting deliveries may be having this, but not all government centers. And this is not at all popular in private sector. It just costs you can buy it on the Amazon. It costs you 6,000 rupees, maybe 100 or 200 rupees less than that. And even if you save one life with this, your 6,000 is worth. So how do you apply? I think everybody can do no rocket science in this, because it is clearly indicated that the 2 number goes with 2, 1 number goes with 1, 3 with 3, and lower limbs, 2 persons should do simultaneously. And afterwards, 1 person can tie from pelvis to abdomen, 1 person can tie. So this was, we had a workshop in 2018 at Rio. Our Fogsi Society did this workshop, and I was posted at this station at that drill. So supportive measures in refractory cases. So what are the supportive measures? This is little beyond the scope of this talk, but I will just mention that massive blood transfusion is required. So we must be, kind of little expert in massive transfusions. Blood products, which product we have to give? You have to give PPF, we have to give recombinant factor 7, whatever you have to give, you should know. Then we should refer it to a tertiary care center after informing that tertiary care center that such kind of patient is coming, which has to be taken to immediately operation theater or a labor room or a well-equipped place for that. So that should be, a patient should be shifted with a doctor, with ambulance, with oxygen and with drip and everything, that not in a patient carrying vehicle. It should be in a life support ambulance. So then surgical steps, finally, we need to do to stop the bleeding. That is uterine artery embolization, internal iliac artery ligation may be required. Then hysterectomy may be required, or then maybe repair of deep tears, which you cannot assess with your normal instruments or visualization things. So now what additional you can do in your clinical practice? That is, for the prevention of maternal mortality, anemia is to be prevented. Then malaria prevention and control, HIV status and treatment if necessary. Then birth planning should be done properly. And complication preparedness should always be there at a birth care facility. So early recognition of excessive bleeding, monitoring the vital signs, laboratory testing, clotting factors, etc. Keep blood ready for typing and with typing and cross-matching. If placenta delivered, always inspect yourself. Reassurance to woman and her family that everything possible is being done for her. Take consent, do time-to-time counseling, do meticulous documentation respecting the timeline of events. Never hesitate to call for help. Inform patient and her family of treatment options, provide reassurance, continue monitoring for status and development of shock. If shock suspected, then begin shock management. Surgical management is obviously what we need to do. That is uterine compression, suture dene hai, uterine this artery ligation karni hai. That all the procedures we all know that we have to do to save the life of the patient. Now, why bundle is the need of hour? The steps of bundle 1 and 2 are very simple and very easy to carry out. They are doable in all types of obstetric units. Quick emergency measures are life-saving for the patient. Timely transfer with this uterine balloon tamponade or this garment is definitely will give a better patient outcome. Bundle concept is well received in OT, labor room and recovery staff. Bundle accomplishes many tasks simultaneously. You know, once you try to teach your nursing staff and your OT staff, they are really excited to learn and they will definitely help you at that time in a better way rather than being lost ke kya mang rahi hai, madam. So then rapid response team you should make. Then medicine equipment checklist should always be there. Twice weekly drills should be done in the early phase. Then you can do once weekly, then once a month. Then once your staff is trained, then I don't feel that these drills are needed. But you, from time to time, we need to check that everything is in place. And every drug which is being kept in our PPH tray, it is not an expiry drug or everything. So that is why I think once a month drill we can keep on. Then team coordination, then your audit. Then this is another thing that is e-motive. It is same, some people call it e-motive. E-motive solution, that is novel adaptation of PPH bundle. 2 lakh women in 4 countries were studied after on keeping this. Then 60% reduction in PPH was noted, and early accurate detection using a blood collection drape is very important. This is very important, I would say, that we should be aware. We should detect that patient is having PPH. We should not delay that. When indicated, immediate first bundle start kar dena, and examination, if needed, escalation to the advanced care bundle. Then this is massage of the uterus, oxytocin, tranexamic acid, then IV fluids, then examination of the genital tract, and then you go for the refractory bundle. So maternal deaths from preventable only with teamwork. So PPH care bundle completes all this thing, and it is very important. So that is why it is being acknowledged by almost every person who is involved in the maternal care. So even our Fogsi also recommends this, and these further studies and everything is going on with FIGO and IDB, that is Inter-American Development Bank, which is supporting this. The golden hour is first 60 minutes after the start of PPH. Greater the delay in starting the resuscitation, lower the percentage of survival. As we all know that great loss of blood happens very quickly. First 20 to 30 minutes is very important. And your response at first 20 to 30 minutes will almost determine how your patient is going to fare in this horror. Rapid response using bundle approach will make huge difference. So now preventable mortality from PPH is our moral duty, and it is really doable. So to combat 4T, that is torn tissue trauma thrombin, it is your tenacity, your strength, your toughness, your team, the readiness of your team. timeline, you need to keep the importance of timeline, when to start what, then training of your people or yourself also. Thank you.
Thank you, Poonam ma'am. Anita ma'am, can we have your comments, please? Gitanjali ma'am had to leave, ma'am, because she was in, she had an emergency. Anita ma'am, are you there?
दिख नहीं रही.
Ma'am, it was indeed a very exhaustive lecture. It has covered almost all the practical tips.
Monica, can I give my comments?
Yes, ma'am, definitely, ma'am.
I wanted to come in because, fact of the matter is that the panel has become extremely easy. Dr. Poonam, I must compliment you on a very beautiful presentation, very nicely, elaborated every point. So,
Thank you.
excellent. And actually, it's like this. सारे questions के answer already आ चुके हैं.
Can I come in?
नहीं, but PPH में you need repetition.
Yes, exactly.
हाँ.
I wish there was a word of
Can I
repetition
come in
with
for a
P.
moment?
Ma'am?
Excuse me.
Yes,
Yes, ma'am.
Dr. Poonam has really done a good job. She has, in brief, she has, क्या कहते हैं, she has told everything and quite in detail also, that how do you have to do, what things you should use, what is the golden hour, and same thing is about that anti-shock garment, that yes, it can be used till that time, but no, ideally you should not wait for that time. You should try to reduce that time so that the mortality is reduced or morbidity is also reduced like that. And you've rightly told about all the steps which can be used, the different types of catheters which can be used, like for this thing, our Bakri balloon, and then condom catheter, then there's that Chhattisgarh balloon and Blackmore sense cannulas. All those things you have really very nicely told in short with photographic details about them. So I think everybody will have will gain from this, and they will have got all the knowledge of PPH now. Yesterday, I was listening to a thing that they're saying that in cases of placenta accreta, you're not supposed to remove the uterus, but you apply sutures. So I was just wondering that another talk where they are telling about this placenta accreta syndrome, I will have to ask them how do they apply these sutures so that it is controlled, because that is a nightmare these days, and you're doing obstetric hysterectomies. So thank you, Dr. Poonam.
Thank you, ma'am.
Thank you, Dr. Poonam. Can I come in?
Yes, ma'am.
Yes.
Because it's my Eid celebration and I have some guests. I would first of all thank Dr. Poonam for this beautiful presentation. And I would say for the beginners, we have to keep in mind, as she rightly said, the golden hour. Golden hour is applicable for everything. Golden hour is even seen in cardiac, myocardial infarction. Say that if you don't give streptokinase within the golden hour, you lose to a heart attack. So similarly, I think golden hour, 2 hours, but we even call it as the 4th stage of labor. This 4th stage of labor has to be very, very vigilant. So what we do in our hospitals, and where there's lots of, where I have worked, and there used to be 120 deliveries. So what was to happen? Patient delivered and shift kar do ji ward mein, that should not be done. Those first 2 hours are very, very important. Very important. And by the time you detect PPH, patient is out of your control. So rather the golden hour or the 4th stage has to be, really taken care of. And then comes all the advances, which Dr. Poonam said, starting from the basic, help and all those medicines and emergency trays and training and PPA drills. Yes, PPA drills are really helpful, very helpful. I have been attending them quite some time, and now we are imparting to our students also. and to the paramedics also, and they have really done wonders. PPH deaths have really, gone down. And then in the periphery, prophylactically, medicine like misoprostol, cytolog, and other are given to the patient, even if they don't get PPH, prophylactic drugs are given. So I think we would more concentrate on the golden hour in the second stage to prevent PPH, and rest, of course, as she rightly said, anemia and other things. It was a wonderful talk. It was a wonderful talk.
Thank you, ma'am. Thank you. Thank you.
Another thing is use of that cannula. I don't know whether you people have used it. That cannula is also very nice for PPH. It
ma'am, वो Panikar's cannula na, but that doesn't come in bundle. That is why I did not.
yes. So I was just saying that is also nice. You just suck the blood. Some blood earlier it will be more, and then it causes negative pressure, and the walls of the uterus, both walls, they get opposed. So no, I'm just mentioning it so that you can try it out in your
But
setting.
important thing is whenever you are using cannula and the pressure is on, you should never remove the cannula with pressure on, because वो पूरे holes में cervical tissue sucked in हो जाएगा और आपको और injury कर देंगे, lacerations of cervix. That is important. So everything has their own ways to use,
Thank you, ma'am.
Thank you.
Thank you, Poonam ma'am, for joining us, and thank you all the esteemed faculties for giving an excellent feedback. I'm sure we have more than 130 delegates, ma'am, who have joined in. They have taken a lot of take-home messages. We now move on to the third session, that is the panel discussion, and I request Shatabdi to please take over as the master of ceremony.
Thank you, Monica. We will now move on to the panel discussion. We have a very interesting panel today. It's a case-based discussion on postpartum hemorrhage. We have two very dynamic moderators with us, Dr. Manju Puri ma'am and Dr. Mitra Saxena ma'am. Can I have the CVs, please? Yes, Dr. Manju Puri ma'am is a professor in the Department of OBGY at Lady Hardinge Medical College. She's also the current president of NARCHI Delhi branch. Madam has various awards to her credit, including the FRCOG Honoris Causa Award, as well as the Fogsi Movical Award for Best Scientific Research Work. And she has edited various books during her career time. Welcome, Manju ma'am. We're looking forward to listening from you. Our next moderator is Dr. Mitra Saxena ma'am. Ma'am is currently the chairperson of the Practical Obstetrics Committee of Fogsi. Ma'am is the director of Shri Ashwini Saxena Hospital at Rewari. She has various publications to her credit. She is a member of various societies like IMA, Fogsi, DGES, IAHR. She has organized various state and national level conferences. And she also has won various awards, including the Fogsi Dhira Award of 2022. Welcome, Mitra ma'am. We're looking forward to your deliberation. Our expert for the session is Dr. Sangeeta Rai ma'am. Ma'am is the professor and HOD in the Department of OBGY at Banaras Hindu University at Varanasi. Ma'am has also been the secretary of the Varanasi Obs-Gynae Society, member of the Clinical Research Committee, and convener of various workshops in previous various national and state level conferences. She has many publications to her credit and has been speaker at various conferences. Welcome, Sangeeta ma'am.
Thank you. It's my pleasure and privilege.
Thank you, ma'am. We have 8 panelists with us today. Our first panelist is Dr. Savita Tyagi ma'am. Ma'am is the director and senior consultant at Ishwar Nursing Home. She is the chairperson of the IS Rural Committee from 2021 till present, and also the secretary of the Agra Obs-Gynae Society. Welcome, Savita ma'am. Our next panelist is Dr. Meenakshi Sood ma'am. Ma'am is a senior consultant at Sood Hospital, Aligarh. She's a life member of the IMA. She's also the master trainer for HPV vaccination and life member of various societies. Welcome, Meenakshi ma'am. Our next panelist is Dr. Alka Yadav ma'am. Ma'am is a consultant at Shanti Hospital at Narnaul. She has over 28 years of experience with special interest being in high-risk obstetrics. She's also the president of Rewari Obs-Gynae Society. Welcome, Alka ma'am. Our next panelist is Dr. Ritu ma'am. Ma'am is a senior consultant practicing at Yashoda Hospital, Cloud9, as well as Max Hospital at Ghaziabad. She is the secretary of KMOGS, vice president of IMA West Ghaziabad. Welcome, Ritu ma'am. Our next panelist is Dr. Kiran ma'am. Ma'am is the president of Faridabad Obs-Gynae Society, member of the Fogsi MTP committee, and the director of Chandna Medical Center, Faridabad, with over 35 years of work experience. Welcome, Kiran ma'am. Our next panelist is Dr. Nigat ma'am. We just heard her. Ma'am is the professor and former HOD at GMC Srinagar. She has been the past secretary of Srinagar Obs-Gynae Society. She has a teaching experience of more than 40 years and she's also the counselor for IGNOU. Welcome, Nigat ma'am. Our next panelist is Dr. Gini Gupta. Dr. Gini is the chief consultant at Healthline Hospital at Ludhiana. She is the general secretary of Ludhiana Obs-Gynae Society and also a Manyata champion and coordinator for Punjab. Welcome, Dr. Gini. Our next panelist is Dr. Preeti Vaish ma'am. Ma'am is the president of Bareilly Obs-Gynae Society. Also, she has been the past vice president. She is practicing in Bareilly for over 27 years. Welcome, Preeti ma'am. And last but not the least, we have... Hello. Yes, and move on to the next one, please. I think we are done.
Well, total 8 completed, ma'am.
Yeah. Okay. So I now hand over to Mitra ma'am and Manju ma'am for an excellent panel discussion.
So thank you. Mitra, I think you can start.
Yeah, actually, they have to give me the right to share the screen.
Ma'am, it's already given. Please
No,
try.
I'm not getting it. No, I'm not able to get it.
Ma'am, just click on share screen.
नहीं आ रहा उसमें white board आ रहा है Zoom post
नहीं,
attendee.
No, not whiteboard, ma'am.
मैम व्हाइट बोर्ड से पहले रहेगा शेयर का बटन. व्हाइट बोर्ड इज इन द नेक्स्ट इन लाइन आफ्टर शेयर.
नहीं, मेरे को नहीं आ रहा. एक सेकंड रुकिए.
मैम
मैंने
प्लीज वो विंडो बंद करके फिर से एक बार ट्राई कीजिए मैम, शेयर स्क्रीन पे क्लिक करके.
कैसे?
वो शेयर स्क्रीन का जो स्मॉल विंडो खुला है वो एक बार आप क्लोज कर दीजिए क्रॉस बटन पे क्लिक करके.
एक सेकंड. अभी क्या करूं?
टॉप पे जाओ.
हाँ, इसको क्लोज करा.
हाँ, अब
अब
शेयर
नीचे आओ.
स्क्रीन एट द
दोबारा
बॉटम.
शेयर करें.
शेयर.
यस.
अभी क्या आ रहा है? नहीं.
No, it's a
अभी आ जाए.
whiteboard, man. It's a whiteboard, not this one.
I have to get
दोबारा
my
बंद करो.
PPT.
हाँ मैम, तो आप एक्चुअली आप व्हाइट बोर्ड शेयर कर रहे हैं, आपको पीपीटी शेयर करना है
तो
मैम.
मेरी पीपीटी तो मैंने खोल रखी है उस पे.
तो आप शेयर
Ma'am, you will have to come to the main screen and click on the share button. Then you will get an option of share the window or share a PPT. You will have to
Wait.
select the share entire window and then you can see the screen
wait,
which you
come
open
slow,
now.
come slow. This has never happened. First time it's happening. So what is showing is select a window or an application that you want to share.
Ma'am, then you can just select the window.
Whiteboard है और Zoom. ये तो पता नहीं क्या.
दूसरा कुछ नहीं दिख रहा मैम.
Zoom आ रहा है. एक
Not
सेकेंड.
Zoom मैम. आपने पीपीटी आपका जो है वो ओपन किया हुआ है मैम.
हाँ, मैंने अपने
डबल क्लिक करके
desktop पे
ओपन.
करा हुआ है.
नहीं आपने
आपका
ओपन
स्क्रीन
किया हुआ.
नहीं मित्रा, अगर
हाँ.
ओपन किया है ना तो ऊपर क्लिक करो, पीपीटी आ जाएगा आपका. पीपीटी खुला
मैंने
नहीं, खोलो
PPT
दोबारा खोल लो पीपीटी.
खोल
ये
दिया.
आपका स्क्रीन शेयर हो रहा है मित्रा, तो पीपीटी इस पे होगा तो आ जाएगा ना.
रुको यार, ये पता नहीं क्या हो गया.
अरे
हाँ,
कोई बात
अब
नहीं,
आ
टेक
गया,
योर
अब आ
टाइम.
गया, अब आ
हाँ
गया. अब आ
Yes,
गया.
yes ma'am. Yes
हाँ
ma'am.
एक्सेलेंट. चलो,
Just make it
यस
full
वी कैन
screen.
स्टार्ट नाउ.
मतलब एग्जामिनर पहले ही नर्वस हो गया.
हाँ चलो.
Perfect.
चलो.
So at the very outset, I must congratulate Priyanka or Monica and the whole team to think up of this really very, very important topic. Dr. Rakhi did a wonderful job with the respectful maternity care. And actually, Poonam has already given all the answers. So it's my pleasure and my privilege that Dr. Manju, fantastic teacher of teachers, is panel moderator along with me. So during the making of this panel itself is a great learning experience. You know, you learn how to even formulate questions. So with that premise, I would like to say
that we all know, as already told many times, that PPH is the leading cause of maternal death all over the world, accounting for at least 25% of direct maternal deaths. What is to be remembered always is that the blood flow to the uterus is so much at the time of full term, that if the natural ligature, living ligature, does not act as per designed by nature, a woman can lose her life due to circulatory failure within less than 10 minutes. The most important thing that we, during the course of our practice and our experience, realize that from a compensated stage to decompensated stage, when a patient passes on, is more often easily overlooked. So that is the reason why PPH becomes such a big demon and becomes a major and rapid killer. And all of us know that it is a preventable cause of maternal deaths. And this is one of the favorite diagrams I like to project. That we all know what all the options that are there, but the only problem is to choose the right one. So as Dr. Poonam had also said, that we all have to know everything, but presence of mind as per the condition of the patient. So Dr. Manju, please, I would like you to come in.
Yeah. So basically, Dr. Poonam has already said that it is the first golden hour which is important. And Mitra has already, said that our skill and our expertise is in finding out a woman who is decompensated. So the problem arises when we, delay in the diagnosis and then delay in the management. Automatically, if the diagnosis is delayed, the management will be delayed. So there are three, PPH actually stands for to predict, be prepared, and to handle. And it is the first golden hour, and every minute of the golden hour counts. Next, please. Yeah. So why do mothers actually die of PPH in facilities when we know how to manage them? So one is failure to predict, then is failure to recognize, lack of preparedness, and failure to do adequate replacement. We either assess it less, the blood loss, or we replace less. And then delayed decisions. I think that is what Mitra had highlighted. And through our panel today, we are going to take some case discussions and talk about each of these points and understand as to how can we not fail in all these kind of things. So over to you, Mitra.
So we all know the very popular adage, too little, too late. And that is the real reason that blood loss assessment, vital signs, we say, but we are not the people actually who are assessing the patient's post-delivery. So low-risk patient profile is those who can, when they land up with PPH, we are not expecting. Then, of course, so many reasons are cited, that overburden units, anemia, high risk. Most importantly, what everybody as a theory knows, but in practice, how to order the uterotonics and for how long. Unfortunately, in the same patient, within that 1 hour, every uterotonic would be given. Is it worthwhile? Or we should just give the uterotonic and do the temporizing method to wait. So these are all the things, like very nicely Poonam has mentioned, aortic compression, bimanual massage. So we have not to forget all these things when we are giving second line uterotonics also. Now, in the panic, in a state of panic, delayed decision making, and not knowing which is the best alternative for that particular patient. So with this premise, I would like to inform our panelists. I must tell the audience that our panelists are all wonderful obstetricians, and none of them have been given any clue about the panel, how it is going to go. The only thing they know is that we're going to have 2 cases in which we are going to be discussing what to do. And in 2 cases, which are real cases from Dr. Manju's obstetric unit, where these are real cases, what has gone wrong, what should have been done. So, I am going to keep this sequence. Dr. Savita Tyagi, Dr. Meenakshi Su, Dr. Alka, Dr. Ritu, Dr. Kiran, Dr. Nigar, Dr. Gini, and Dr. Preeti. I hope all of them are here. So we will go with the first case. This is a patient, very commonly a primary built, normal built, 100 gram, 10 gram hemoglobin, had induction of labor at 39 weeks, no complicating factor. Bishop was 4. 1 time Savai Prime gel was given, oxytocin was given, ARM was done, normal vaginal delivery with episiotomy. The total duration of labor was more than 18 hours because obviously patient wanted normal delivery and the obstetrician also wanted the normal delivery. AMTSL was done with oxytocin. After episiotomy was stitched, there was sudden gush of bleeding. So I would like our first panelist to, we are delivering this patient. Who would like to take Dr. Savita? Will you like to take this question? So Dr. Savita, when after you finish the episiotomy and before the patient is shifted out, I mean, this is a lucky situation for the patient. What would be your step when she has a gush of bleeding? What is your message
Because
to?
She took more than 18 hours. A little bit prolonged labor was there. So it may be because of the prolonged labor, it may be atonicity of the uterus, which may cause the bleeding in such cases. And we have to see whether the uterus is contracted or not, what are the vitals to the patient, and what other measures we should take at this moment, because oxytocin trimers has already been given. Then we have to look for the other patients. And we should also look into the or not. It was the sudden chances of disease are more in this patient. So we have to look into the patient this patient, and we should always look into the vitals, maintain the vitals of this patient very closely.
Okay, actually, I'm so sorry. At my end, the connection was very poor. I would like to ask our second panelist this question, Dr. Meenakshi. Is Dr. Meenakshi over there?
Ma'am, she is not there. Meenakshi ma'am
Never
is not
mind.
there.
Dr. Alka, considering that this patient was, 18 hours in labor, would you give oxytocin or would you give something else for AMTSL?
Good evening, everybody. Mitaji, actually, this patient has had a prolonged labor, so we should be in watch for this, that she may go into PPH.
Yes.
Because of the uterine atonicity. So the first thing we like to see is the tone of the uterus. And if we find it during, I would like to prefer कि during the stitching of episiotomy also, we should be trying to see the tone of the uterus. It's not that we are just stitching the episiotomy and we are not bothered about the uterus when we have had one precipitating factor. So
no, actually what I want to tell is that regular AMTSL was done by syntocinon. So as a routine, now that carbetocin is here, have you made any change in your practice? I'm not asking, I would say, like for me, I have changed my practice so that we don't have this in between intermittent. So I would like you to comment on this, that is it a sensible option to, in these high-risk patients, to give carbetocin? That was my point.
I have tried carbetocin personally in these cases and I find it very useful. Instead of going for oxytocin, that is the first line we give during the delivery of the baby, and just immediately after delivery we are giving. But if I find the tone is not there, so I'll first like to go for carbetocin. And if it doesn't respond to that, then I'll like to go for another the tissue trauma has also to be ruled out together with the
for
tone.
sure. Sure.
Can I
Okay.
make a point? Mitra, can I make a point?
Dr. Manju, please. Yes.
So I guess whenever you have all these patients who have been getting induction of labor, it is important that with that passive management with oxytocin or with carbetocin, we must make sure that the symptom drip is off. We must add 10 units of oxytocin to the drip and ensure that it continues for next 6 to 8 hours.
I don't know at my end.
Patient, if oxytocin is used for the induction, then carbetocin will not act because they both act on the same receptors.
No. What I'm trying to say is, if when patient is undergoing induction, then they have an idea to continue, increase the oxytocin receptors and continue it for next 6 to 8 hours in addition to the active management. That is what I'm saying. Right?
Okay, I think Manju, if you
Can
can just
we,
put it in the chat box, I will announce because
Dr.
I
Mitradi,
I'm unable to hear. Yeah, Kiran, please come in.
can we give, we can also add methotrexate to such patient. If the bleed is from the lower segment, it is not contracting well, then it will act on the lower segment.
Yeah, for sure. Actually, my main intention was that in prolonged labor, in overdistended uterus, in patients who are, we are expecting that they will have atonic PPH, I have personally changed my practice to using carbetocin and not oxytocin, which I always give for AMTSL. So I've asked Dr. Manju to put her comment in the chat box so I can speak it out that what does the evidence say. But this is my personal thing. AMTSL is for all of us are doing, but many obstetricians have changed over to carbetocin. I will request Dr. Sangeeta, if madam is there, can she comment on this point that have they all started carbetocin in all high-risk patients for AMTSL? Dr. Sangeeta? Dr. Nigat, madam is there?
Ma'am, can you hear me?
Yes, Dr. Sangeeta, yes, please.
Thank you, ma'am. Actually, in our tertiary care unit, we are in a medical college. Carbetocin is as good as oxytocin. And in fact, in some points, it is much better than oxytocin because the duration of action is very, very prominent and it is a long stay of duration. Action stays long for 1 hour. And the side effects of oxytocin is also very minimal. There is no problem with the room temperature, but yet it is a costly drug. So in some high-risk patient, we individualize the case. Depending upon that, we give carbetocin. But still now, we use oxytocin in most of our patients.
Yeah. So, I mean, like, this is just my own learning as well. And that we have to open up the use of carbetocin, especially when we are already expecting atony. This patient was lucky that on table before she was shifted out, the uterus relaxed. And so the gush of bleeding could be picked up. Now, I want to ask, in a routine case, when will you insert the second cannula, draw the sample? That means to say, at what point will you, be alarmed that this patient cannot be shifted out and we have to do further management? Who would like to take this question? Dr. Guinea? It is the connectivity is little dicey. Dr. Savita, Dr. Kiran, are you there?
Yes.
She has delivered vaginally, and if the bleeding is around 1,000 ml, so I would like to insert the second cannula because it is a signal for the danger signal, and if the bleeding is not being controlled within 30 minutes, I should insert the second cannula and should draw the sample for cross-match.
So I think, we all know that if there is atony, as like Dr. Savita in the very beginning had mentioned, that we will rule out the trauma to the cervix and the vagina. And if it is only purely atony, we will manage it with uterotonics. And of course, if there is excessive blood loss, we will be going with the full, scenario. Dr. Manju, would you like some comments? Otherwise, we will go on to.
Mitra, I think that, instead of the duration of the visual amount of blood loss, I think vitals of the patient should be looked into. If she develops tachycardia, if she develops tachycardia, that means she's already in stage 2 shock. So let's start with the second.
Yeah, so this is a very good message. Thank you, Dr. Manju. This is most important. If our patient is clinically stable and the uterine atony has been taken care of, then with full instructions, we can shift. Otherwise, with preparedness in mind, that if she again bleeds, we have to be prompt in taking her to the next step with, the vital signs of patient in mind and amount of bleeding. So, what are the instructions for monitoring such a patient who has had atony, who has shown one bout of atony? What will be the instructions? How carefully the patient must be monitored in the post-labor room. I will request Dr. Guinea, if she's there, to take this question. Dr. Guinea, Dr. Preeti, anybody? I'm not able to see everyone.
For 1 hour, we have to take every 15 minutes, we have to observe the patient for
Yes.
uterine
Yeah.
atony, and BP and pulse should be taken, and the mental status and the general condition of the patient is to monitor for such patient. After that, we can increase that time after half hour, then 1 hour. After that, up to 4 to 6 hours, we should observe the patient for every 1 hour. If patient is all right, then we can decrease that.
Yeah, I really agree with you, Dr. Kiran, because although the 4th stage is only for 1 hour, but a woman who has had atony, it's not just the 1 hour. As you said, if a patient stays stable for 6 hours, the chances that she will have any more complication is, far less removed. So that was the answer I was looking for. And in case patient has a bout of atony in the postnatal ward, what should be the preparedness in this primary from a obstetric point of view? So Dr. Sangeeta, Dr. Alka, I can't see others actually. Maybe
If this
She is not
patient develops
responding.
I can't see others. So I think we will be flitting between us 6 people. Dr. Savita or Dr.
She is not responding to oxytocin drugs.
No, she
Then
has
we can-
responded. She has, her atony is taken care of. She has been shifted out. Instructions as per Dr. Kiran has been given that patient is being monitored. And if she has another bleeding, in our own preparation, what should we have ready? If she has atony again after say 3 or 4 hours, what will be our next step? Will we just repeat the uterotonic, or we would like to do something additional? What preparedness we should have? That is what I want to know.
The patient to the operation theater, fully equipped operation theater, then we can put these tamponade to her uterus, because she has been given oxytocin, and then she again had this tonic PPH, and also we do the all preparation. If we have the tertiary care at our place, then we can do all the things at our place, like these tamponade. Then if needed, then we can do these surgical methods like suturing, these uterine arterial embolization, or internal iliac artery ligation. That is very much important.
Dr.
And we
Manju,
should
I would
also
like your comment, please.
blood components.
Yeah, Dr. Manju.
Yeah, it's important that we have a plan of action, and because she should try and have all the conservative procedures in our hand. So that should be the plan of action. Meanwhile, we should give full replacement. She should be well compensated. She's not in a shock kind of a stage. We not replace the blood and we not replace the fluids, so that even a small bout can decompensate. So I think we should keep her absolutely at a stable condition. And if she has a bit of bout, we take her to the OT, and with proper consents and all, we move. But it is not usual for a patient, if she's well controlled, to have a repeat bout after 4 hours. Usually not. So
Yes.
Usually, either we missed a tear or something else is there. It cannot be only pure atony.
Yeah, so all the things that Dr. Poonam had already mentioned, evacuation of the uterus and continued tone of the uterus. So basically, our learning has to be that PPH does not end at the delivery of the patient or 1 hour later, at least 6 hours, and we have to be prepared. So I just wanted to mention transvaginal uterine artery clamps. I don't know if any one of you or us are using it, but yes, all of us have seen it's used by Dr. Piley. And I think it is a sensible, clamp to have in our labor rooms also. I'm also planning to actually make this purchase, because sometimes, despite everything, or maybe on table, this is a kind of temporizing method where we can clamp the uterine arteries transvaginally, and it's very simple. So that is there. And aortic compression is another thing, which is important to remember for buying time. So that was this routine, like an atonic PPH also can create havoc and, actually make the patient land up into big trouble. So, as already stated, that a PPH drill is really important so that everyone knows what is to be done. And like Dr. Manju said, I apologize from Dr. Manju's side because she is traveling and I know it's very difficult to convey. But the most important things is that our, whole team's assessment of the patient, the blood loss and our readiness. That's the whole essence of managing PPH. And of course, if anything wrong happens, we have to document it properly, move according to the timeline, and debrief the patient and the team. So this is a beautiful picture, pin-up girl, and I'm sure all of us have it in our labor room, which shows how everybody has to be positioned at the time of managing PPH or any emergency in the labor room. So there is the person who's delivering at the perineum, who is actually, suppose even if the patient is delivered and come back to the labor room, there is one senior obstetrician at the perineal end who's going to be announcing that what is the next step to be done. And at that point, also doing the massaging the uterus, coordinating, catheterizing the bladder, looking for any, other reasons for PPH. If it has not been done, which it should be done, but ruling out any tears which have been, missed. And on the side, we have the arms. On one side, on the right side, the person is to check all the vitals, IV access, and one person at the head end to check the airway, breathing, give oxygen, give sublingual mesoprostol, and note all the times. Because this person is not doing anything active in terms of managing the, bleeding. But of course, putting the sublingual mesoprostol, giving oxygen. So these are things, and I think every one of us has it, who all have done this Manyata training would be having this. Already, I'm not going to, flash it again because Dr. Poonam has taken this very carefully. And the second case, Dr. Manju, should I do this or we will go for the real cases?
No, you can do this, Mitra, and I'll take the real case.
Okay.
Yeah.
So here again, now we have already talked about atonic PPH, and the next, worst scenario is when you have the other T. So here is a primey. Actually, last night only this happened with me. So only thing is that my patient didn't have epidural for pain relief, but this is a primey after induction of labor. She did not push properly and she was in the second stage for 2.5 hours. Ventouse was applied, undiagnosed phase 2 PEEP delivery occurred in 2 pulls. Baby with good mother, ABGAR, but mother exhausted. So actually, AMTSL was done, placenta removed, and before episiotomy, the vagina and cervix was explored. What was found was a tear in the vaginal wall going high up towards the vault. Vagina was quite edematous and there were minor lacerations on the right side too. Who would like to take the management of this patient? How would you like to do, Dr. Kiran, Dr. Savita, one by one? Dr. Kiran.
I will like
Dr. Kiran?
Yes, ma'am.
Yeah. So
For this-
you have taken out with vacuum and before even stitching the episiotomy like a conscientious obstetrician, you have explored in your labor room and there is a spiral tear going high up towards the vault. Although the patient has epidural, but she's quite exhausted. So what is your plan of action? How will you do this?
I will see that whether I can take the tip of that tear. If I can stitch above that tear, then it will be fine. We have to, because such patients, they have hematomas. We have to avoid these hematomas. We have to stitch that. But if the tear has gone up in the up, then we will have to open that patient. We will have to tell the patient. But if we are taking the tip of that, if we go above the tip of that tear, then we can stitch that patient.
So my question, basically, let me reframe it.
Yes.
I want you to answer this question. Will you start stitching immediately or will you like to arrange some things, or does your labor set has everything already. That's the message I want the audience to know. So
I
what
will
will
first,
be your instruction?
I
Yeah,
will
okay,
look
Dr.
into
Savita.
the hydration of the patient. I will hydrate the patient properly, will catheterize her to see the output also, and I will call my friend obstetrician to help me out because the tear is very high, and I will also take the help of anesthetist. If the epidural is working, then it's okay. Otherwise, I have to call the anesthetist also because such high tear we can't stitch without taking the help of anesthetist. So these things we have to look into, and we have to take the proper stitching because it is edematous. So we have to take care of taking the stitches that these are not, we can put the stitches properly.
Exposure should be good.
Very
Exposure
nice.
should be good.
So Dr. Alka, would you like to summarize what Dr. Kiran and Dr. Savita have said?
Yes, ma'am. We'll like to examine the patient if she is properly anesthetized, it's okay. But for this patient, we need to relax her before going for stitching or proper examination. And a laparotomy set should be kept ready. OT should be kept ready with the help of the anesthetist, so that if we are able to stitch the vaginal laceration properly, it's okay. If not, then we'll have to open up the abdomen and do it abdominally.
So I just want you, Dr. Sangeeta, can you add what are the instruments that you should instruct all our, attending people to make note of, which should be there available before we start even, any
The
stitching?
most important thing, madam, before going for repairing such a tear, it may be exceeding above the vault into the broad ligament. So we have to counsel to the patient attendant that we need to evaluate the patient, monitor the patient post-operative also. If the patient deteriorate, then we may have to again open the abdomen. But first, we have to have a proper exposure, proper light, proper anesthesia, lithotomy position, and dressing and draping. And we need to have minimum 3 sponge holders. That is most important. Okay, to catch the cervix and go to the fornix, the lateral fornix, then the posterior fornix, and again the anterior fornix, and evaluate the tear, how high it is. If you can go above the tear, we can very nicely stitch it.
So thank you so much, all the panelists, because we are almost reaching there.
Madam,
The only thing I
yeah, ma'am.
wanted to add
Ma'am,
was, yeah, please
Ma'am,
do.
I usually use the Devers retractor. I use Devers retractor with the light. That is what I use.
Done. Agreed. That is exactly what I wanted. Large, long-bladed sim speculum or narrow Devers. Because we really need these retractors, because we cannot look at the vaginal vault if we do not have these things. I also personally have placed long Ellis forceps and of course sponge holdings to look at the cervix properly, and good light. And like Dr. Alka and all of you have said, the presence of an anesthetist or patient and another colleague, definitely they will assist you better than your own staff. So maybe you need 2 assistants. Whatever you do, my adage is do it right the first time. A tear in the vagina, we should really respect it, inspect it. In which way has it torn the vagina, so that if we put the stitches appropriately, we will not cause later, scarring and shortening of the vagina, because in that hurry makes curry. So that happens. So I'm really grateful to you all, because you all have actually together summed up. So the commonest tendency, of course, is to start stitching this tear. Patient is already in epidural, but my thing is that have a team, like Dr. Savita has said, IV lines, of course, we are having blood if the blood loss is there. Anesthetist also said good light. OT if the things are not available in the labor room. We can pack the vagina and do it nicely after telling them, because pressure actually takes care of a lot of bleedings. And like my panelists have already said, Devers, long Ellis, long these instruments. So basically, this is really, really important to have all the tools with us before we start doing it. And let's do it right the first time. Now, somebody will like to tell us, Dr. Sangeeta, that, when we are dealing with vaginal tears, what are the complications? And Like, sometimes it is just coming out. How do you manage edematous vagina, tears, straight tears, which are easy, and spiral tears? What are your, learnings? What are
Madam,
your
basically, these are very, very, very tribal tissues. So we have to just very, very tribal tissues, madam, because it is edematous. So the most important, we need to understand that we have to go for interrupted sutures. We
very
have to
right?
apply interrupted suture. That is important, and we have to lock the suture sometimes. And we should not unnecessarily uh, pull the sutures. That is most important. And then we have to pack the vagina after giving the interrupted suture. That is, I think, much important. And rest, ma'am, it is the observation and all the vitals monitoring,
Yeah.
as we all do.
Yeah, I think this is the most important thing which you've already said is that the suturing of vagina should never be continuous. It has to be interrupted. And of course, you can take 1 or 2 locking stitch, and uh, site of the tear is very important. If it is on the lateral side, fine, you'll not be compromising. But if it is posterior midline, definitely you have to take care, respect the rectum and all that, so that you don't let your stitches should not pass through. And one never knows, how the tears will happen. Sometimes they will be just spontaneous tears also. We've seen on one side, we've given the episiotomy and the tear is on the other side. So we have to, really be very careful and packing the vagina. That's it. Dr. Manju, would you like to answer? Because I think our panelists have done a fantastic job of, enumerating all the important steps of managing traumatic PPH.
Yeah, I think all the points have been taken care of. What is important is that while we shift the patient, we all do pack the vagina, but I think packing or stopping the bleeding while we are shifting the patient becomes very important. Whether it is atonic PPH or it is traumatic PPH, it is important that we keep pressure on the areas which are causing bleeding, right? So I think that is it. Rest all has been beautiful.
And bladder to be catheterized for,
Yes.
we have packed the
Those
vagina,
steps.
and good antibiotics and good, pain management. That goes without saying. So I think I've done my cases, because I just wanted to keep very simple recap of how to manage atony, how to manage trauma. So now these are real cases with Dr. Manju sharing.
Yeah. So Mitra, maybe you can read out the case. I'll take the discussion.
So I will let the panelists know that these are real cases where there was maternal death, and please look at all the points carefully, and so that the questions will be what went wrong. So this is a 40 years, Gravida 4, Para 3, L3 with 40 plus 3 days pregnancy with moderate anemia, undergoes induction of labor in view of cross. Yeah. Yeah. Is it okay? Shall I continue? Cervical ripening done with Foley's catheter, followed by oxytocin infusion. Has vaginal birth, baby girl 2.78 kg after prolonged induction. She had atonic PPH managed with uterine massage and oxytocic agents. IV RL started and received 1 unit PCV and 1 bag of RL. BP pulse blood pressure, pulse 104, BP 102/62, uterus well contracted. After 2 hours, got up to pass urine, felt dizzy and passed a big clot. On examination, uterus well contracted, re-explored in labor room. A cervical tear was identified, same repaired. Pulse 130 minute, BP 96/50 mm. Another unit of PCV started. Uterus became atonic, bleeding plus, Bakri balloon inserted. Patient shifted to OT for hysterectomy, had a cardiac arrest on the table, and the patient was lost. So the questions to the panelists, if you have looked at everything, so I think one panelist can take one question. What were the highest factors for PPH in this mother? Dr. Manju, how would you like it to be done?
Yeah. So Mitra, we can ask one question and go back to the history and show this. I think that would be a good idea.
Yeah, that would be very nice.
Yeah.
So I think Dr. Kiran, you take this question. What were the high risk factors for PPH in this mother? I'm going back to the case. You can look at the patient profile again.
Please list out all the high risk factors. Yeah.
This is because she is 40 years elderly and multi-gravid also. And the induction was also done. So these are the
And
factors. And moderate anemia is also there. So moderate anemia,
So,
and
yes.
she's post-dated and multi-gravid, and the age factor. These are the risk factor for this.
Absolutely. Yeah. So that means our, preparedness has to be very high in this kind of a patient, right? So over to the next slide, Mitra. Next question.
So, next question is to Dr. Alka. What is your assessment of volume of blood loss in this mother after initial episode of atonic PPH?
Back.
Actually, the
I'll go
pulse
back
rate
to
is
the
going.
slide. So you
Pulse
see,
rate is going high. She is already, and the blood pressure is falling. So she's had more than 1 liter of blood loss. 1 to 1.5 liters we can assess at this time. And so we have to manage her for the hypovolemic shock at this time.
no, we're not asking you for management at all. You just have to answer this question. What is your assessment of volume of blood loss in this mother after initial episode of atonic PPH? Where it is written a big clot, past a big clot. So
No,
you
no,
write
she's
there,
already
Past the big clot the second time.
Dr.
The first
Alka, you
oh,
rightly.
yeah. Sorry.
Yeah.
I missed it. Yeah, 2 times.
Yeah.
Okay, yes.
So the first time the vitals are stable.
Dr. Alka,
Yes, ma'am.
would you call these vitals as stable? That is what I want to know.
Tachycardia
A
is there.
pulse of 104 and a BP of 102/62.
Patient is basically not stable, we can say. The patient is having moderate signs of PPH. So we have to manage these.
No, is the patient in shock? No, no.
Already
Is the patient in shock?
No, we cannot
No,
call her
pulse
that
is
she's in
more
shock.
than pulse is more than the systolic BP. She is in shock.
Yes,
she's in
shock
hypovolemia. Yeah.
Yeah. So I think that is where the message is that, with because her shock index is more than 1. So it is pulse divided by.
Hello.
So I think the signal is lost.
Connection बहुत unstable हो रहा है.
हाँ, वो actually train में है ना. Sorry. So sorry. So I will tell you. The idea is this, that she already had atonic PPH, and now when she was in the ward also, this patient should have been, was a very big red flag. Her pulse and blood pressure were matching. So if we look at the shock index, it is almost 1, which is, she's already on the brink of, you can say.
Yes.
She's not stable.
Yeah. So this is a compensated shock, right? So let's move on to the next question.
Yeah. So, Dr. Savita, she was given, I'll say the question first and then you go back to the slide. Was the volume replacement adequate? How do we decide on the volume replacement after PPH? So in this patient, please look at the fluid.
We talk about the first instance only. Yeah, she received 1 unit of Paxil and she received 1 unit of Rigalactate. So do you think this was sufficient?
No, ma'am, because when this patient was having pulse 104 and BP was 102/62, it means it was not properly hydrated, this volume was not done, because this shows this is 104/102 is less than, 102/104 is more than 1. That means patient is in the shock, and this volume what has been given is not adequate for her. And again,
that is right. What I am wanting to ask is, how much volume replacement are you looking for in this patient?
Because she is moderately anemic already, and only 1 unit of PCB has been given, then it is not sufficient for her. And there is again at least 250 to 500 blood loss after the delivery. So at least 2-3 Paxil should have been already given to this lady.
Yeah. So I think what important point we come here is, one is that a pulse rate alone of 1.4 is not sinister. And a BP systolic of 102/62 is also not sinister. We normally don't worry about these kind of situations. But if we look at a combination, then it is not good. That is why we must always look at the shock index. Now, this patient has lost a significant of blood loss. Okay, so if it is IV fluids we are replacing, then it has to be 3 times. 1 for 1 ml, 3 ml. If it is blood, then it is 1:1. Right? So that means this patient did not get adequate amount of replacement.
Yeah.
All right. Can we move on to the next question?
Yeah. So how should a patient be monitored after PPH? I think, Manju, we have taken this already. Dr. Kiran had mentioned already that the patient has to be closely monitored. So pulse, blood pressure,
Urine
respiratory
output
rate,
is
urine
also
output.
important.
Yeah, urine
Besides
output very
vitals,
important.
urine output is very important.
So what measures can we use while shifting the patient having PPH to the OT from labor room? Now, let me go back to the case. This patient had re-exploration in the labor room when she had another big clot, and uterus wall contracted, so she was explored, and she was shifted to the OT for hysterectomy. So what should have been done?
By manual uterine compression, one should keep the one hand on the abdomen and one hand in the vagina, so we can minimize the bleeding from the uterus if it is atonic. Another thing is we can also do the aortic compression by pushing the uterus to the right side and keeping the hand on the left side of the abdomen, to the
Ma'am,
side of
Dr.
the
Savita, because we know that this patient we have lost. So do you think that when, after she was re-explored, and when we found that the pulse was so high, she was already in shock, and then although unit was started, do you think that atonic bleeding should have been managed by Bakri balloon?
No, ma'am. No, ma'am. It is, I am just telling when we are shifting the patient from labor room to OT. In meantime, how
No,
can
no,
we
I am saying
reduce the
about
blood
this
loss?
patient. And let us just
Yeah.
stay in this patient.
The
Matlab,
Bakri balloon is not should not have been done in this patient because she is already in shock, and we can't wait more for such patients to do these such type of.
so I think, because what we are addressing is that this patient had cardiac arrest on the table. So the reason of cardiac arrest must have been hypovolemic shock, and which was not adequately managed and mismanaged, although the timeline is not given, but definitely these things happen over a little bit of a prolonged time. And atony हो गया है, चलो अच्छा अब हमने tear rule out कर दिया है, फिर से uterus well contracted है. But what is important is that after you have resuscitated, have you looked at the vitals of the patient? Are they stable or they are not stable? If they're not stable, you can't manage. So I think lot of time was lost in Bakri balloon and managing atony when a patient was already decompensated. So surgical, maybe they would not have needed to do a hysterectomy, but they should have intervened with the surgical management earlier than late. This is what
Internal iliac artery ligation would have been done.
maybe not internal iliac artery, because it was atony and this, maybe compression sutures, stepwise devascularization, whatever, because tear was repaired in any case. Anyhow, so I think
And madam, we can also consider for putting NASG
huh?
because we can also consider to put
that is,
NASG
very
during
good.
that
So
time.
basically,
That is important.
I think so much of time should not have been lost, especially at this time. Now, if we look at this, when she had first bout in the labor room, then in the ward, and if she is this unstable, this is not a vital sign at which blood is started and balloon is put. This is, I think, one very, very important, learning thing. Balloons and all are put if patient is not in shock, or at least you find that after you're putting the balloon, the bleeding is, stopped. That's why Bakri or this Chhattisgarh balloon is important, because there is an outlet drain. So, Dr. Sangeeta, would you like to comment on the use of balloon, because either people don't use it, or if they use it in a inappropriate way, we may still lose the patient. We may lose time actually. That is most important. So please give your message.
Ma'am, it is a very good method, especially in case of atonic PPH. And we all have to train ourselves. But because when we read the video, we see the video, and when we are going to put the balloon, it is very much different practice. And because there's so much of a stress, so we have to keep the set ready, especially in all these patients where we predict for PPH, atonic PPH. Every patient can go into prepare PPH, but high risk patient, we have to predict and be ready for EMB placement. That is most important. The tray, the condom, the catheter, the normal saline, everything should be ready. And then we have to put and give a dose of antibiotic. And we have to see the vitals of the patient. And in between, we have to do all the supportive management like IV fluid, blood and blood products, especially the component therapy. This is very
Yes.
much important
Yeah.
to save these patients.
So the very nice, rightly said, Dr. Sangeeta. Yeah, Dr. Savita.
Mitra, can I come in now?
Yeah, please. Yeah, I was waiting until you were
Yeah,
not.
yeah. Dr. Savita, please go ahead. Then I'll talk.
Yeah, I want to add one thing, ma'am. I have used these tamponade for the to control the PPH in cases of antepartum hemorrhage like placenta previa, and it worked very well. And I afraid of bleeding in patients of placenta previa, especially if the placenta is lower down, then I have used it. It's I want to share.
So basically, you know, what I want to tell you in this case is, can we go back, Mitra?
Yeah.
So you know, one is that to know whether the patient is already in shock or not. So that is the shock index, right? Because it happens with everyone. It is not that it happens only, you know, it has happened here. It could happen with anyone. We always need to look at her baseline blood pressure when we look at the present blood pressure. So maybe her initial blood pressure was 120 and now it is 102. Right? So that is one thing. The second thing is the amount to be, because she was moderate anemia, everyone was scared giving her fluids. You know, by the time the blood came, they gave her only one VAC, thinking that she's moderate anemia and she might go into, you know, pulmonary edema. So that is another thing which you have to keep in mind. And these patients, you should give fluids, rush fluids. You can give it as bolus. Give 500 ml, rush it, then give another 500 ml rush and see the chest simultaneously. The third thing was what Mitra had discussed, that post, you know, atonic PPH, monitoring is very important. And what I said was that in that duration, while you are monitoring, the blood should be replaced. Not that if she becomes stable, then we don't replace the blood. Because, you know, we should understand in this case that she needed at least 4.5 liters of fluid if no blood was available. And in case blood was available, she needed 1.5 liters of blood. So which is a huge amount, at least 4 or 5 pack cells, right? So that is why, and we don't normally give all these replacements immediately. But unfortunately, she had another bout and she got knocked down. And in that bout, that preparedness which Dr. Mitra was saying was also important, that we should immediately have that plan in action, that a Bakri balloon or something will be put and we take her for you know, definitive kind of a management to the OT. So that is the timing is very important. So, you know, and all this happened and there was a change in shift. So the previous team had gone, the second team had come. This may not happen in private sector, but in public sector, it does happen. So these are all preventable points. And that is why I brought this patient here to be discussed, right? Thank you.
Thank you for clarifying that, because actually, once the patient is unstable and in shock, definitive management will be done. And in using the Bakri balloon, of course, we have to make sure that the vitals of the patient are, you know, stable. A patient who's already 130 pulse and low BP, and if we just put a balloon and think it is work, it's not going to work. Maybe as a temporizing, yes, but not, you know, unless her blood pressure comes up, her pulse comes down, and she's replaced adequately with the blood, you know, PRBC.
Mitra, this Bakri balloon was as a temporizing method. With this Bakri balloon, she was shifted, right? It was not a definitive method. But she had lost so much. Yeah, but she had lost so much that we had not replaced. That is why we lost this patient.
The
Yeah.
replacement speed was, I think, very,
The
not that-
diagnosis, no, the diagnosis was delayed. The management was delayed. Both the things were delayed.
everything.
Yeah.
So then I think we let's come on to this. We have not yet discussed that most.
Yeah, this can go to one of the panelists. That what are some specific conditions or confounders, wherein the healthcare providers underestimate the actual blood loss, leading to delayed diagnosis. This is one of the cases, but there are other conditions also. So can someone list out those conditions wherein the assessed blood loss is lesser as compared to the damage it is caused?
Concealed PPH, where ma'am the vagina may have a clot, big size clot, as happened in this patient.
Yes.
Uterus is basically from the upper abdominal examination, we feel that it is contracted. But the lower segment may be relaxed and that blood has accumulated in the vagina. So when the patient gets up, it becomes dependent, and that is basically concealed PPH, we can say.
And something interesting also is there that sometimes, when you see the pad, there could be some serous fluid there. So it is a retracted clot which brings out fluid. So that also should raise a signal in your mind that this patient could be having a clot inside. Right?
And then the underestimation of what the fluid should be replaced, how much amount of the fluid has to be replaced, that can also be cause for falling vitals.
That is the management issue. But the diagnosis part, I want you to tell me more conditions where even a small amount of blood loss may be dangerous and may cause, PPH.
Anemic patient, she has been anemic, so that anemia can also be that cause for loss of this thing. And then the previous condition during the labor of the patient, if she is already not well hydrated, that can also lead to this thing, increased amount of blood loss.
So all prolonged inductions, right? That ripening induction, in private sector, it may not happen. The patient is well hydrated. In labor rooms, if they have been there for 2 days together, then, they are usually dehydrated and they cannot tolerate the amount of blood. What else? Certain other conditions.
Yeah, if there is
a short stature woman, what blood circulates in our body is 100 ml per kg. So if you have a 35 kg woman, right, her blood circulating would be almost 4 liters. So she might lose lesser amount of blood and be in shock.
Yeah.
So short stature, PIH, dehydrated, anemic patient. In all these patients, the amount of blood loss may be lesser, but her condition may be more precarious.
So basically, it is, I think, Dr. Manju, if we can add this human quality of denial, an obstetrician is in denial of, itna sahi to hai types. No? So there,
Absolutely.
we have to really go on to actually, start adopting these drapes and all that. So we can actually have objective assessment of the blood loss. Okay, so Dr. Manju, should we go ahead?
Yes, please go.
So would you like to please explain so that we can complete it quickly?
So this is what we were trying to say, that how do you assess the amount of blood loss? So one take-home message is shock index, which we have to look up. Okay, then we should know how much estimate of blood loss. So if you look at the estimate of blood loss here, so if you see the first stage, class 1, with almost 1 liter of blood loss, there is usually no change in the parameters except in those conditions where patient is short stature, she's dehydrated, she's PIH, she's anemic. But in case your patient has a heart rate of more than 100, like our patient had, that means she's already lost about 15 to 30%. So 1.5 liter lost, right? So that should hit your mind. If the shock index is more than 1, that means your patient is already in shock and we need to replace her aggressively. And in case her BP also falls, maybe this patient already had a baseline BP of under 2. It was only that the shock index was more. But supposing the BP falls, then she's already lost 2 liters of blood. So, that should hit our mind that this much is the replacement required. We don't actually go by that till such time the patient is 80 by 50 or, 90 by 60. By that time, she is already heading on for, stage 4 and she might go into irreversible. So any patient who is uncomfortable in the labor room after delivery, say she's uncooperative, signals which we need to catch, and like Dr. Alka had said, that it could be a hematoma which is found inside. So I think that is what is important, to assess the amount of blood loss correctly.
Yeah. So let's go on to, we've already, Dr. Manju has told. And
Go
I
ahead,
can,
next.
Manju, shall we go to the next one?
Next.
So shock index, Dr. Manju has already said, very simple, heart rate over systolic blood pressure. Normal is 0.5 to 0.7. In pregnant, it is a little bit 0.7, 0.7 and 0.9, because a pregnant woman can have a little bit of increased pulse rate. But if it is more than 0.9, it indicates hypovolemia. If it is more than 1.2, it indicates patient needs blood transfusion. This is the simple line to Ratto. Blood loss is more than 30%. She will need blood transfusion. So example is heart rate is 120, blood pressure is 100. So shock index is 1.2. So I think
this is very useful in pre-eclampsia, Mitra.
Yeah.
Because, there if the blood pressure is 130/90 and the pulse is 130, then she's still in shock, no?
Yeah.
So
We
that
have
is
to know that PIH patient, the intravascular compartment is already contracted. So, she will not show a fall in blood pressure as quickly. So we have to be very much aware. 160 से अगर 120 भी आ गया तो भी हमें उसको मानना पड़ेगा.
मित्र, इसमें एक कैच है, क्योंकि हम लोग माइजो दे देते हैं ना, तो कई बार फीवर आ जाता है पेशेंट को, तो वो भी ध्यान में रख लेना चाहिए.
Another thing is there are other reasons for tachycardia also. We've seen a patient in pain, patient anxious will also have tachycardia, but that will be fluctuating, and that will, that will not be a stable heart rate. But when the patient is tachycardic because of loss of blood, definitely that pulse will not come down. But so many times we see that thoda 5-10 beats ka farak aa jata hai, but we have to also see that what is the blood loss and all. So of course, but shock index is something which is easily trainable to our staff also. So as a precaution in my post-op, post-delivery, we have a multi-para on all the patients, and for another 1 hour at least, उनका हर 15 minutes में वो WhatsApp पे डालते रहते हैं, which is our way of, sitting in our house and making sure our patients are not going to call us again. So, rule of 30, Dr. Manju?
ये छोड़ सकते हैं. I think we've already done that.
हर चीज 30 है. Percentage loss 30% है, BP loss than 30 mm.
Systolic अगर 30 fall करता है.
Respiratory rate, fall in hematocrit, and output. Very important is output. Anything and everything. If the vital organs are fine, that means the kidney especially and the heart, the patient will come back. But if the kidneys get knocked off, then we are in for very big, sad state.
And also the color of the urine.
Yeah.
That's important. If it is high colored, we must understand patient is in. बहुत बार patient ये लोग कहते हैं जैसे cesarean में loss हुआ, फिर बोलते हैं output कम आया, है ना? और वैसे वो कहते हैं कि fluid तो हमने दिया. इसका मतलब जो loss था वो हम नहीं पूरा किया उसका at that time. So इसका मतलब blood loss significant रहा होगा ना? तो ये भी एक चीज है. So I think we can skip all these things. I think time हो गया होगा.
I think,
What is the key message?
The most important thing is, Dr. Sangeeta, will you like to comment on this? Our expert for the day, Dr. Sangeeta. Please quickly just...
Not an expert, exactly. Yes, ma'am, because we have going to the PPS bundle approach, and very clearly, we all know that nowadays we can use very, very cost-effective the bead rate, where we can assess the blood loss. And coming to the sponge method or a pack method, the gauge piece method, it is not very reliable, but if it is fully soaked, the swab is fully soaked, then we consider it as a 500 ml of blood loss. That is very important. And the gravimetric assessment is also not very, very authentic. We basically go with the hemodynamic instability of the patient. Any hemodynamic instability relates to shock. So this is very much important. That is the message I want to give to everybody.
I go
This is
with
a new
you.
kind of a AI. Yeah. Go ahead,
Uh-huh.
Mitra. Go ahead.
Yeah. No, I go with Dr. Sangeeta a lot because what is, we will underestimate and our methods may overestimate. So basically, if we go at the vitals of the patient, we will never miss. So that kitna bhi ho, agar patient stable hai and stays stable and our all methods are in place, we are making sure that the uterus is well contracted. That is one very important thing, that is not intermittently relaxing. So I think I go with you, Dr. Sangeeta. But these, these drapes are very important. And, all our agencies that are working with our government of India and Foxy, they are ready to give these drapes and they are available in the market and we can actually improvise also. So those who are having personal, experience, it'll be good that this can be popularized. It makes sense, but definitely.
Mitra, I would like to make a point.
Please
Actually,
do.
when you are called for help, तो एक बार वो सब सिस्टर ने ड्रेप वो सारे स्पंजेस रखे होते हैं, तो मेरे को लगता है आप जाते ही हम लोग पेशेंट मैनेज करने लग जाते हैं. तो एक असेसमेंट ऑफ ब्लड लॉस जरूर कर लेना चाहिए जब आप हेल्प के लिए जाते हैं, है ना?
अगर
क्योंकि
नहीं
जब
भी
न्यू
रखा है तो पूछ तो सकते ही हैं.
हाँ, तो ये इम्पोर्टेंट है, क्योंकि नहीं तो हम ना डिसीजन ऑफ वेदर टू स्ट्रेट अवे गो फॉर हिस्टेरेक्टमी और टू गो फॉर इंटरनल लाइगेशन, ये चीजों में थोड़ा सा ट्वीक हो जाता है.
Bilkul. It is very important actually. That is why we have so many, methods to estimate it. But definitely, at least we should have our own way to assess the blood loss.
नहीं, और ये आपको रिप्लेसमेंट में हेल्प करेगा ना, कि कितना लॉस हो, आपको कितना रिप्लेस करना है ना?
अगर सक्शन यूज हो रहा है तो सक्शन जार भी मैम एक बार वो चीज
बिल्कुल ये रखा.
बिल्कुल,
that has to be taken in point.
Very important. Yes.
So volume replacement ka, what are the basic rules to replace the volume?
Anyone
I think
can
Dr.
say.
Manju is already told.
If
you're replacing with crystalloids, no colloids, only crystalloids and blood and blood components.
Yes.
So if it's crystalloids, then 3 times. And if it's blood, then it's of course as much equal. So 1 liter, 3 liters of crystalloids. And if hemorrhage is torrential and cross-matched blood is not available, unmatched O negative blood can
ये भी दिमाग में रखना चाहिए, ये हम लोग भूल जाते हैं, है ना? मतलब उसको क्रॉस मैच की वेट करते रहते हैं, तो ये भी आई थिंक इज अ गुड थिंग टू कीप इन माइंड, है ना?
Yeah. And of course,
this is something, this is important because इसका हमें अंडरस्टैंडिंग क्लियर होना चाहिए. अगर हमारा डायल्यूशनल कोगुलोपैथी हो गया, पीटी इज मोर देन 1.5, राइट, तो हमें 4 यूनिट्स एफएफपी एक गो में देने चाहिए, सिंगल बोलस डोज, और फिर दोबारा पीटी रिपीट करना चाहिए. इसका भी थोड़ा रैशनल तो होना चाहिए. और प्लेटलेट्स अगर लेस देन 50,000 है तो पीसीवी देने का कोई फायदा नहीं है और एफएफपी देने का कोई फायदा नहीं है, प्लेटलेट्स ही देने हैं. और प्लेटलेट्स रिमेंबर कभी फ्रिज में स्टोर नहीं होते हैं, उनका स्टोरेज 21 to 23 डिग्री होता है. अगर फ्रिज में प्लेटलेट्स रखे हुए हैं तो वो बेकार है. ये भी इंपॉर्टेंट है, राइट? क्योंकि ये चीजें ऑब्स्टेट्रिशियन को भी पता होनी चाहिए. सो इसमें हम जब एक एसडीपी जंबो पैक बोलते हैं तो 30,000 प्लेटलेट्स बढ़ जाते हैं, और अगर हम आरडीपी बोलते हैं तो एक से केवल 5,000 बढ़ते हैं, तो इसका मतलब हमें 6 देने पड़ेंगे यूनिट्स, है ना? तो ये भी बोनस रहेगा. सो एक दो देने का कोई फायदा नहीं है. और दूसरा, फाइब्रिनोजन इज समथिंग विच इज वेरी इंपॉर्टेंट. जो हम लोग भी अभी इसमें जा रहे हैं वो ये है कि हमें क्रायो देना चाहिए, क्रायो प्रेसिपिटेट. फाइब्रिनोजन सबसे इंपॉर्टेंट कंपोनेंट होता है जो वॉश आउट हो जाता है, तो उसको हमें एट एनी टाइम 100 से मतलब 200 के आसपास रखना चाहिए.
ठीक है, थैंक यू सो मच.
So ma'am, it is available at your place, cryo precipitate. It is available because sometimes we are struggling. Ma'am, I have just a question. That is, cryo precipitate is available at your center?
Sorry,
because
go ahead.
we are always struggling with the cryo precipitate availability.
Yeah, it is available. Yes.
Okay, at your center because we are
yes, it is available.
having problem.
Okay. हाँ, नहीं, पर हमें कोशिश करनी चाहिए, जो हमें चाहिए. अगर हम वो मांगेंगे ही नहीं तो बात कैसे बनेगी ना? मतलब हमें we have to grow, no, with times, right?
Yeah. Thank you, madam.
Yeah.
So Dr. Manju.
Go ahead, Mitra. Yeah,
Yeah.
isko chhod do. We can go ahead.
So we know the massive transfusion protocol, definitely. I mean, let's hope nobody gets into that. But the important problem is of dilutional coagulopathy. You are actually, catching at both the ends. Volume replacement as well as replacement of all the platelets and all the clotting factors, coping up with multiple problems.
अब
And
इसमें 1:1:1 होता है, सारी चीजें 1:1 चलती है.
हाँ.
ठीक है, I think that should be all. I hope no one gets into that.
I know exactly. Before I started, I said that.
Yeah, but
Normally,
अगर
बच्चे तो
क्या करते हैं, फर्क्रीटा वगैरह करते हैं तो ये रेडीनेस होनी चाहिए.
हाँ, ठीक है. Okay. So, do we have time for case 4? I think we don't.
इसको छोड़ दो मित्रा. No, Mitra, this is almost similar. We can leave it.
So the take-home message: too little, too late.
Yeah.
Right, Dr. Manju?
नहीं, go ahead, Mitra. आप बताओ, Mitra.
Sorry?
You can take it.
Yeah, so basically,
you go ahead and say.
I think we will finish it off because it's already 7:30. है ना?
Yeah.
So basically, we all have to understand that too little, whether it is in diagnosing or in the replacement or in the management, or it is too late. The recognition of the blood loss is late. The recognition of replacement is late. So at every place, a delay actually costs us a life. So basically, the principle of managing PPH and all these problems is have a good team, your own colleague who will stand by you, a good anesthetist, all your tools in place, all your staff well trained, and of course, the decision making. And never, never underestimate the power of PPH. That I would say, and I don't wish it on my worst enemy also. So we need, PPH is a common obstetric emergency and can occur even in the absence of any risk factors. Sequential and systematic management can go a long way in preventing maternal mortality due to PPH. Every mother counts, so act on each minute of the golden hour. The golden hour of recognition of hemorrhage, whether it is immediately after the delivery or even after once the patient has been shifted into the ward. So maybe after 4 hours, 6 hours, whatever. I don't have, we think we have time for this, no?
No, I think we can omit.
Yeah. So I will say thank you.
I think a lot of interesting discussion has taken place.
Thanks a lot to the organizers. I don't know whether they're still there. At least 6 of us are here. 4 or 5 of us are here.
And the panelists also, they've done a good job. I think it shows everyone was so experienced. It is just kind of recapping how we can kind of improve further. I think that is what is important.
Yeah, the finer points. Like I like to say, Dr. Manju, that theory में सब बहुत perfect है, practical कैसा करते हैं ना? This is what a panel is. So thank you, Dr. Sangeeta, Dr. Savita, Dr. Alka, Dr. Kiran, and anyone else. I should not miss anybody's name. Thank you so much.
Thank you, ma'am.
Thank you, ma'am. That's an excellent discussion.
It was really
You always
nice.
learn a lot, ma'am.
No, the
with your
good thing about
previous
our,
speeches.
I want to put it on record that this panel knew nothing about what's coming on their way. So I think, Monica and all those who are there, please give a big hand to our panelists. जैसे PPH आता है ना out of the blue, ऐसे ही ये questions थे. But I'm glad कि हम लोग सब पहुंच ही गए, जो भी हम चाहते थे. So thank you so much, Dr. Manju. Thank you so much.
So my apologies for all that glitches. I was off for some time, but well done.
But Manju, I think, this is what is PPH, right? Team building. So all the panelists and we kind of pulled it through.
Absolutely.
Thank you so much, ma'am.
Thank you.
Thank you.
Thank you, ma'am.
Thank you.
Thank you, Mitra, ma'am. Thank you, Manju, ma'am. Thank you, Dr. Sangeeta, ma'am. And thank you to all the panelists. My heartfelt gratitude and thanks to our Fogsi President, Anuradha ma'am, Abha ma'am, the two beautiful talks by Rakhi ma'am and Poonam ma'am, the chairpersons, Anita ma'am, and all the panelists and our moderators over here for the lovely discussion today. Wish you all a very good night and hope to see you all soon again. Thank you so much.
Wishing all of you a very happy Eid in advance too.
Yes,
Yeah.
yes. Happy Eid in advance. Yes.
Thank you, Manju ma'am, and thank you, Mitra ma'am, for accepting our invitation and being the torch bearers for this panel discussion. And the delegates have a lot of take-home messages for sure. And I am delighted to inform you that we have more than 150 delegates today online, ma'am.
Great.
Thank you, ma'am. Thank you, ma'am.
Congratulations.
Thank you, Sangeeta ma'am, for joining in as an expert too.
My pleasure. Learned a lot again.
Thank you so much, ma'am.
Thank you.
Good night, everyone.